inflammation is going on. Okay. So that is the time, if you evaluate properly and if you find a reversible etiology like BC, autoimmune, Wilson's or even NASH, and you sufficiently treat that, you can prevent a future cirrhosis. So these are the basic concept. Because of the flight schedules, because of the Sunday schedules of many chair sessions, it may be possible that the session you will be rewarded for the chairing may be changed. Timing of the lecture may be changed because many faculties have to leave by the 2 p.m., 3 p.m. because they have return flight or train. But we will try to accommodate each and every question as much as possible. At the end of the session, there is a quiz of 21 questions. Okay, and we will play it on the Telegram. So if you have not download the Telegram, please download it and join the group called Gujarat Gastro Update 3, and winner will have a prize. Okay, now someone has asked me that what is the prize. Okay, so price doesn't matter. Okay, because you have heard the story of Sachin Tendulkar. Okay, Sachin Tendulkar once has been interviewed and asked by the reporter, okay, what is the best asset you have? Okay, so he told, okay, when I used to do a net practice, my coach used to put a 1 rupee coin on stumps, and he gave challenge to the bowlers, if he can bowl me, that 1 rupee coin will be given to the bowler, and if I remain not out throughout the day, this 1 rupee coin will be mine. So I have a formality to reduce consumption of the time, like I will ask chair session, then felicitate the chair session. We are like a family. Okay, now I am in insurance since last 8 years. Okay, we know each other. Okay, we have a mutual respect for each other. Okay, so only felicitation and moment will be given to the faculty. Certificate and chairperson, that time we try to reduce, so you can be more interactive and you can ask more questions to our faculties. Okay, in my session, the chairperson who is who are late little bit, but I request Dr. Kishore Virodia, Dr. Vijay Lukhi, Kaushik Dalal sir, okay, and Dr. Dhiren Bakshi sir, please come on the stage. Okay, and if you feel that this is not my session to chair, but it doesn't matter, it is very easy to do a moderation. You have to just ask questions. You don't need to give answers. Okay, that will be my part. Okay. Please upload my presentation. Okay. So in my lecture, first of all I have given the heading that cirrhotic should not be died. Then I realize everybody is going to die. Even a healthy person is going to die. Okay, there are only 7 mythological characters in Indian mythology that is immortal. That are Hanumanji, Ashwasthama, Maharishi Vedvyas. Otherwise, everybody is mortal. Okay, so when we see the cirrhotic patient, what is our aim? Our aim is, please upload my presentation. Our aim will be first, evaluate the etiology. If there is any reversible thing, you can revert it. First motto. Second motto, suppose it is irreversible. Think it is a burned out cirrhotic. It is in the child B, child C. Now we are not going to do much. Then try to optimize the treatment so they can prolong the survival with good quality of life without transplant till the time donor is available or such a case, okay, but there are few minor things I have noticed that we can implement in our practice, and by 1% we can make a difference of 30-40% in the waiting time at least. Okay, because now majority of patient able to gather money, okay, at least upper middle class, but the biggest problem is donor. Donor is not easily available. So if you keep your patients in the waiting list of the some cadaveric transplant program, okay, you have enough knowledge, enough keenness and enough willingness to optimize that patient till the time liver is available. Okay, so how can we optimize that patient? Now, suppose cirrhotic patient, there are one very good lecture which is the intermittent albumin therapy in this. This is the one of the recent advance in the liver disease in which you can prolong waiting time, which optimal time without decreasing the quality of life. Second, the most important thing is education. There is a, if you see the data, there is one study says, if you educate the patient regarding that disease, suppose for the CLD, okay, if slightest degree of fever, wait for a day, agar fever rehta, you start antibiotic. Even if you are in a remotest place, start.
So this minor knowledge will reduce the hospitalization at least by 30%. 30%, and that is a proven thing. Any chronic disease, if you give education and the just get, suppose this happens, you have to start this tablet and patients start at home without your observation, then even it is around 30% reduction of the hospitalization. So great improvement in the quality of the life, great reduction in the financial burden, so they can accumulate their money during the waiting time for the transplantation. Okay, so what basic practice I noticed during this is, first is the loss of hope from both the end, from physician as well as patients. Once patient diagnosed with the cirrhosis, most of the physician says now game is over, now you have to go for transplantation. Most of the patients or relatives also ask for 2-3 things, okay, and somebody has told कि no, once cirrhosis happens, okay, everything is over, transplant करवाना है, otherwise तो कुछ नहीं होता, patient मर ही जाता है. Okay, and you see, that is the human tendency. If patient dies, it spreads very fast, that's things. But how many patients survives, how many patient is doing good after transplantation, that we have to explain. खराब, जो खराब है वो जल्दी ही फैल जाता है. Suppose everybody know, I have given the example many times, okay, everybody know the name of the terrorist who have attacked the Taj. But how many of you know the name of the Havaldar who caught the terrorist with his hand? How many? So that is Havaldar Tukaram, but nobody knows Tukaram, because good thing needs to be marketed. Bad thing has a own. All bad thing is like malignancy. They attract everyone. They pull everything. Okay. So don't lose hope. Second is the unnecessary ascitic tapping. Or suppose patient comes कि सर बार बार ascites हो रहा है, okay 2 liter tap कर दो. Just to what we call the reduce our time consumption, and just to give mental satisfaction for the patient, but that is not. Avoid diagnostic tapping which is necessary. Suppose patients with ascites comes to you with the fever, usually because of we are in private practice, we start antibiotic, we don't care about doing a tap. We start antibiotic, 5-7 days, patient is okay. You ask patient, then it is okay, you stopped antibiotic. Suppose that fevers happen due to the spontaneous bacterial peritonitis. You have to give antibiotic lifelong. Okay. Second, and Once SBP develops, transplantation requirement is much higher. It is the one of the indication that now this patient require transplantation. This patient require intermittent albumin therapy. Okay, so any fresh decompensation in ascites, if you feel we are not able to find another cause before giving a shot of antibiotic, you should do a at least gentle 5 ml tab. Underuse and overuse of albumin, that will be discussed by faculty. In SBP, we fail to diagnose and we fail to give prophylaxis. Suppose you diagnose the patient with the SBP, you have to give antibiotic continuously. Okay. Labeling of the refractory ascites. You say, but you have not know the what is refractory ascites. You have not optimized the dose of diuretics. You have not see the salt restriction compliance of the patient, and you just say your ascites is refractory, go for tapping. Giving 3% saline in hyponatremia, that is very very common what I have seen. Now hyponatremia in cirrhosis is somewhat different than the hyponatremia of old age. It's a hypervolemic hyponatremia. So treatment is the fluid restriction. It is not the 3% saline. Okay. So treatment is the fluid restriction, and in few cases of ascites, even it is not refractory, we have advised patient to go for the fluid restriction, which is not necessary. Okay. Cirrhotic ascites is different from the cardiac ascites. Okay. Fluid restriction is more required when there is a cardiac ascites. Depression is up to 57% of patient with the cirrhosis because of the loss of hope, and waiting list mortality is 25%. I think if we focus on the optimization and proper education, these two parameters we can definitely impact. Okay, if you see the one of the study for the HCC, I will just speak for the 5 minutes because we are already late. And after that, Dr. Mithun Sharma from the AIG, he is right now giving lecture in the DDW. Okay, so he will do lecture online. Okay, and after that, Dr. Amit Pandit and Dr. Pankaj Puri sir will be there. Dr. Pankaj Puri sir is my teacher. Okay, and I used to call him anytime when I am in difficulty. Okay, so HCC, if you see the 65% patient don't know, okay, we have to go for the 6 monthly USG and alpha fetoprotein, and this study is from Canadian journal. Okay, 15% patient has a despite you explain, only 15% turn for the biannual surveillance. Okay, not known about the guidelines in 68% of the primary physician. We don't know. If you ask, okay, why should you go for 6 monthly USG, 6 monthly alpha fetoprotein, even for the primary physician they should know. Okay, and there is another study that understanding the primary care and specialist mentality model of the cirrhosis care, and it say that somebody says that we are not fully updated, somebody says that we don't have time, somebody lost hope because we educate the patient but they don't follow. So there is a difference in the mentality. I feel, suppose I organize this conference and I feel that despite of such a good faculties and such a updated knowledge, okay, the peoples are not coming. That is my mentality. Okay, in your end you are thinking how this is help in my practice. I am asking patient every time but patient is not following. That is your mentality. So this study is in the changes of the mentality or evaluation of the mentality of the super specialist, broad specialist and primary care physician. Now all this, if time permits, what is the indication of ascites tapping? Okay, we can do at the 3:30 p.m. I will be here only. Okay, but right now, okay, we are asking Dr. Mithun Sharma. Okay, so he can be on Zoom on live, and he will, because he has a compulsory schedule, he has another talk of 12:30 at the DDW, best of DDW. So he just now completed his talk, and in 3:30 p.m. if time permits, if you are interested, I will continue with my talk. Anything right now you want to ask for 5 minutes for this or anything, what is the ascitic tapping, we can do this till the time Zoom link will be activated. Please, sir. Drug of choice in depression in the liver cirrhotic. You see, basically, any drug which is not very sedative, you can, or means chlordiazepoxide, haloperidol. Okay, we are using it in the severe state. Okay, so basically you have to differentiate the type of depression. Okay, because many of these patients is a alcoholic, they have a mood disorder. Okay, so there may be a, sometimes it's a psychosis, sometimes it's a depression, mood fluctuation. So usually I ask psychologist or psychiatrist to evaluate what type of depression is there, and then they usually ask, mostly they are using sertraline or a mirtazapine with good amount of safety. Okay, but to be very honest, myself, I am not treating a depression. If I feel, we have a team, we have a Dr. Bhavna Raja as a psychologist. Okay, we have a Dr. Nirav Choksi, Dr. Piyush Goyal as a psychiatrist. I will ask them, you decide. If they have doubt that this drug is safe, then and then I will tell yes, this is safe. But there are few drugs which is really hepatotoxic. Suppose the misconception upon paracetamol, how much paracetamol you can give to a cirrhotic? પછી ઝૂમ લિંક ચાલુ થઈ ત્યાંથી? સાહેબ વાત હતી. So then you switch to a Zoom link. Morning, sir.
Morning. So I just, you have to activate, give me the permission to share the screen.
Please give them permission to share the screen. This is Dr. Mithun Sharma. He is from AIG Hyderabad, and I heartily thankful to him because despite of his busy schedule, because immediately after this lecture, he has another lecture at DDW. So thank you very much, sir.
Thank you so much. So I'm just not able to share the screen because the host has disabled. That's what is coming.
You just able them to share the screen. Give him a power to share the screen. You can ask. Mike. Oh, okay, please.
Yeah, you can take the questions till the screen is ready. Okay, it's come, I think, now.
One of the question from the audience, sir, which is the safest drug in the depression with the child cirrhotic?
Yes, so in cirrhotic child C, honestly, we use a drug preferably with a shortest half-life. If it's a disorder of patient not sleeping and it's not encephalopathy, we would prefer to give something like a very low-acting oxazepam or zolpidem. But antidepressants, otherwise sertraline has been used because it's used in cirrhosis with itching if it's a long-term requirement. But we should be very careful because if it's a sedation and encephalopathy needs to be differentiated. Yeah, so is my screen visible?
Yes, visible, sir. Clear.
Yeah. So thank you so much, and I'm extremely sorry I could not be there in person. Last time I was there, it was a wonderful experience. So today I've been asked to talk about therapeutic plasma exchange in liver disease. So my job is to just give our experience and what is the data, and maybe at the end of the day, it should be possible to start a plasma exchange program in the center where it is required. So therapeutic plasma exchange is synonymously the term that is used is plasmapheresis, and to be in very simple term, it removes the patient's plasma and filters it and sends it back. This is nothing new, though papers have been list in liver. It was first employed in 1952 for myeloma control of viscosity. And there has been, if you see, a list of disorders where plasma exchange have been used, starting from significant data on myasthenia gravis to CIDP in neurology to prevention of transplant rejections, multiple sclerosis. Possibly liver is one organ which came late into the party, and so we are discussing about therapeutic plasma exchange or plasmapheresis, or shortly we call it as PLEX in patients with liver disease. So one needs to understand some basic concepts. So first is we have to understand what is blood volume or what is plasma volume. So 55% of our total blood volume constitute plasma, which roughly equals to 39 ml per kg for males and 40 for females. And the total blood volume in our body is equal to weight into 70 kg divide or for males or 65 for females. And we can calculate plasma volume by this formula, 1 minus hematocrit and total into total blood volume. Don't get panicked by this because this is done mostly by the person who is in the blood bank. So we'll give you an example. So the first question when you want to do a plasma exchange is, how much plasma to exchange? So let us take this example of a 60 kg-year-old person. This is the dry body weight of the person who had a hematocrit of 29. So the first step is to calculate the total blood volume, which will be 60 multiplied by, because it's a male, into 70, which is equal to 4,200. This is the total blood volume as per this formula. Our next job will be to find out the plasma volume. So plasma volume will be the total blood volume multiplied by 1 minus the hematocrit, which is roughly coming to 3000 ml. So this is the plasma volume that is required. When we use the term standard volume plasma exchange, it is roughly equal to 1 time of the plasma volume, which will be 3000 ml. If we use a high volume, or many people call it double volume plasma exchange, it is 1.5 times into the plasma volume. So in this patient of 60 kg, this is how you calculate the total blood volume, the plasma volume, and then decide on which one to use. Which one to use, I will just show the literature. And how do you prepare it? We don't give this entire 3000 ml as plasma. We mix it at either 1:3 ratio. 1% of them would be albumin, and the remaining 3% will be fresh frozen plasma. So if you are using, say, 4500 ml, 1000 ml will be albumin, and 3500 will be FFP. So the machine that is required, so this is the machine that we use at our center. The approximate cost of this machine, it comes from KB. It's around 30 lakhs. And I think the cost of the procedure with the hospital charges varies between 50 to 70,000. What is the principle of plasma exchange? So you need a central line. Blood from the patient will come out through this and go into this machine. So what goes from out of the patient's body is the whole blood, and you see it goes into the machine. And immediately the machine discards the patient's plasma. And then you have 3 columns on the other side. These are input devices, which will have an acid citrate dextrose, albumin, and plasma. Initially, the anticoagulation goes inside, followed by the albumin, followed by the plasma. And then this is filtered, and what goes back into the patient's body is a combination of PRBC, this anticoagulant, and fresh frozen plasma. So therapeutic plasma exchange in liver disease has been used in multiple conditions, including encephalopathy, severe alcoholic hepatitis. A new paper has come, drug-induced liver injury, Wilson disease, and in transplant setting, both in pre and post-transplant settings. For the constraint of time, I will not go to other extracorporeal devices, but the basic concept of plasma exchange is that in liver diseases or liver failure, there is loss of hepatic detoxification leading to the accumulation of endogenous toxins. And it is believed that this extracorporeal liver support system, which in layman term I will label it as dialysis, will possibly be able to remove these toxins. It always is a bridge to transplant, and it never should be promoted as an alternative to transplant, though there will be some scenarios where it can be life-saving. There are many ways which these toxins can be filtered. We know there are artificial liver support systems like MARS, which have been used lots in the Western countries, and bioartificial liver support systems, which can be either hepatocyte-based or porcine hepatocyte-based. The literature is very scanty in terms of survival benefit, with only 2 studies with a very few number of patients like 13 and 24 showing benefit survival benefit when compared to standard medical care. Similarly, there are no studies which showed survival advantage with the bioartificial devices. So, coming to the question now, we have gone to the rounds. We told our resident that do a plasma exchange. The first question he will ask is whether to do a high volume or a standard volume. Now, the answer to this is not straightforward. There are two extremely contrasting studies. This was the first study which was done in the West. The basic concept was that, again, following a hepatocyte death, there is release of these inflammatory cytokines, and it was hypothesized that if we do a high volume plasma exchange, it could reduce the mortality. And the primary endpoint was the study was a transplant-free survival. This was more of a proof of concept study, and they believe that by doing a high volume plasma exchange, there can be 20% improvement in survival. They included patients of acute liver failure, but excluded patients of alcoholic hepatitis. As a protocol, everyone received N-acetylcysteine, and they defined raised ICP as more than 20. They defined high volume plasma exchange as 15% of the ideal body weight, and they removed plasma at a rate of around 1 to 2 liters per day, and they did it on 3 consecutive days. So this table shows the mean plasma exchange duration versus standard medical care, how much plasma was exchanged in the first session. If you see, it's a huge volume, around 9 liters have been exchanged, and it showed that the number of median hospital stay in patients with high volume plasma exchange was significantly was less, though it did not receive a statistical significance. The only thing that was significant was that the survival to hospital discharge was significantly better in high volume plasma exchange. Whether it was a paracetamol related ALF or a non-paracetamol, it did not matter. The study had some secondary endpoints, most of which we need in our clinical practice. It usually reduces the bilirubin INR. This study did not show an effect on the serum lactate despite the inflammatory markers decreasing. There was a significant improvement in the mean arterial pressure. Therefore, the need for vasopressors was significantly better. The other scores that we do in the ICU, like the SOFA, CLIF, and SIRS, all of them showed a descending trend. So the study concluded that high volume plasma exchange improves the transplant-free survival at 3 months, and those patients who were listed for transplant who did not get a liver also had a better survival. The part 2 of this study showed that markers of endothelial dysfunctions and cytokines showed an improvement, and though we thought that there is a risk of sepsis and coagulopathy, it did not happen, and the authors concluded that this was because of the immune modulation that we have done. We have removed the toxins, so there has been a significant improvement. So this first study concluded that by doing a high volume plasma exchange, we are reducing the inflammatory cytokines and thereby reducing the DAMs and leading to a favorable environment, an anti-inflammatory environment, leading to a benefit in the patient's survival. Now, this study was followed for many years. However, there has been a recent study. This is from ILBS Delhi. So this study is again on acute liver failure. And this study raised a very pertinent question that when we are transfusing or exchanging such high volume of plasma, cerebral edema is always a concern in patients of acute liver failure. And it was felt that the volume of plasma exchange of 15% was arbitrarily chosen, and that volume overload can worsen cerebral edema. So they designed a study where they would give a standard volume plasma exchange within 12 hours of hospital admission, and other parameters almost remaining the same. So in patients who required renal replacement therapy, was continued only for renal indications. They classified the patients into rapid responders, those patients who responded in less than 3 sessions, slow responders, response in more than or equal to 3, and non-responders who did not respond even after 5 sessions or showed deterioration. They included 40 patients of acute liver failure. They excluded patients with untreated sepsis. And if you see, the number of volume exchange was almost half of that was done in the previous study, and it showed that there was a significant number of patients were rapid responders. Even in one session, 6 out of the 11 patients responded. There were some patients who were non-responders. The majority who responded were those who had a viral etiology, and non-responders were mostly female patients and who had a lower pH at baseline. Again, there were slow responders were the ones who were presented with a lower platelet count or who were requiring dialysis and had higher SOFA score. This study also had secondary outcomes. We showed that there was an amelioration of sepsis, and in contrast to the first study, this study also showed a decrease in the lactate by day 3, which is an important marker in acute liver failure. Also, similar to the last study, they showed an improvement in the mean arterial pressure and the SOFA score, with no difference in survivors as regard to the ICU stay. So this study again concluded that the 21-day transplant-free survival between standard volume plasma exchange and the standard medical care was better. Also, there was an amelioration of SIRS in 2/3 of the patients. There was a decrease in the inflammatory cytokine, DAMs, and a significant decrease in a von Willebrand factor, which indicates that microcirculation was improving. And there was a significant increase in interleukin IRA, which is like anakinra-like molecule, which will have an anti-inflammatory action. So this study also concluded that standard volume plasma exchange can lead to a significant improvement in cerebral edema. It led to the sparing of dialysis in 70%, and early initiation was the key, and the lead for vasopressors, though was lesser than the previous study, was also reduced by this protocol. So these are the only 2 randomized controlled trials of plasma exchange in acute liver failure. Now I have summarized here the role of plasma exchange in acute liver failure. As you see, more ACLF, acute on chronic, most of these patients are on hepatitis B. Most of these are on, by definition of the APASL criteria, and almost everyone shows improvement in the 3-month survival, though none of them showed that a long-term outcome was good. So it can be at this point of time promoted as a bridge to transplantation in patients of ACLF who are in the ICU, and we need to buy some time for transplantations. There are some other indications which we have used also in our clinical practice. Patients with deep jaundice coming with intractable pruritus, you have tried everything, nothing works. In these patients, there are reports of using plasma exchange in PBC patients. What was more interesting was that the pruritus decreased as expected, and the antipruritic effect persisted in 90 days after follow-up. And it did not matter whether these patients were cirrhotic or not. So they included these patients who were not responding to UDCA, rifampicin, and then plasma exchange. People have tried plasma exchange in chronic fatigue in PBC, though we don't see so many PBC patients in our day-to-day clinical practice. There is also a study which shows that the cytokine levels can be effectively lowered by plasma exchange. Coming to 2 very interesting, these are all case reports, plasma exchange in Wilson disease. So this is a patient who had Wilson disease, and it shows that plasma exchange was done, and this led to a successful liver transplant as a bridge to therapy with use of triantine. And there is a report of plasma exchange in Wilson disease where the patient recovered without a need for transplantation. So our protocol is that if we are using plasma exchange in a Wilson disease, we use it till the patient can afford or the patient recovers or goes for transplantation. This is one indication where the results are very interesting. So coming to a summary, there are a lot of extracorporeal devices. So this is a network meta-analysis which shows that the only out of these Mars, Prometheus, or all these things, plasma exchange is the only one which has shown to improve the 3-month overall survival when compared to the other extracorporeal therapies. We use plasma exchange in ABO-incompatible liver transplant. As you know, if we are transplanting from an incompatible donor, there is increase in anti-A and anti-B antibodies, which leads to rejections. And plasma exchange can rapidly reduce these titers which obviously can rise after a few days. So to prevent that, we use along with it a repeated exchange and give also rituximab. We target a titer of less than 1:32, and then it shows that it is successful to suppress this for 3 weeks, and by that time, the immunosuppression start and the patients can be taken up. Whether we can give heparin-free or unfractionated heparin, there has been studies which have compared both and found to have no statistical significance. There may be some pediatricians there. Data is very scarce on extracorporeal liver support system in pediatric patients, but there is emerging data in acute liver failure, and it is recommended to continue this therapy to pediatric patients also, where we can use 5% human albumin. So this is the guideline which says that an expert consensus which feels that high volume plasma exchange can be used as a bridge to liver transplantation. And it is recommended that we explain the patients that this is a bridge to transplant. And in acute liver failure, we should try to do it on 3 consecutive days. The duration of each session should be titrated based on the patient's fluid overload status between 6 to 8 hours. We should keep in mind of metabolic alkalosis as a side effect of this procedure. So respected chairpersons, the take-home message for today is that plasma exchange can be beneficial in patients of ALF and acute on chronic liver failure. In ACLF, it serves as a bridge to liver transplantation, while in ALF, like if it's a paracetamol poisoning with a background normal liver, Wilson with a normal background liver, it can be just a rescue therapy and patients can escape transplant. It acts by filtering the pro-inflammatory cytokines, endotoxins, and improving the anti-inflammatory cytokines. It can improve the MAP, leading to a decrease in the need of vasopressors. The need for renal replacement therapy is also decreased. It has not been shown to of any benefit as of now as in severe alcoholic hepatitis, though a recent study has come where you combine plasma exchange with a lower dose of steroid and see how it works. It is beneficial in managing pruritus and fatigue, promising results in Wilson disease. Systemic review suggests that plasma exchange may be the most beneficial among all the liver support system. However, proper patient selection, avoiding patients with untreated sepsis. We usually, as a protocol, if there is a sepsis, we try to control with antibiotics for at least 2 to 3 days before we push for a plasma exchange. And whether we do a high volume or a standard volume is supported by 2 separate papers in ALF, and the jury is still out. With this and permission of Soman, I would like to invite you for our conference, which is on 30th June at AIG Hyderabad. Thank you so much. I would be happy to take questions, if any. Sorry, I'm not able to hear. Yeah.
Am I audible, sir, now?
Yeah, you're audible, yeah.
The center where transplantation is not available, and you, according to your talk, acute and chronic liver failure is a most promising data right now. Okay, so how will you choose this patient? Can this patient now, without sepsis and rather than waiting conservatively, start plaques?
No, see, there should be it doesn't depend if the center has transplantation or not. We are just buying time. The first step is to talk to the family whether there is transplant on the other side of the window or not. So if there is a transplant, family needs time for logistics. They don't have a donor or donor is unfit. It needs a 2-3 months time. These are the situations where it can be very helpful because it acts as a bridge. So we can obviously shift the patient to a transplant center if the patient survives that ICU admission, because we know in ACLF, the 28 days mortality is very high, close to 40%. So by doing a plasma exchange, we are reducing that mortality and giving the patients a chance to go for transplant, if at all that option is there.
But any biochemical parameter or anything you follow?
So we are doing as a research protocol. We do actually in our center, this paper is about to be published. We are doing endotoxins and cytokine levels before the procedure and within 12 hours after the plasma exchange. So based on that, we are seeing a decrease in these inflammatory markers. But these inflammatory markers do rise again after a few days. So this is a bridge therapy always.
But this inflammatory markers is not available easily in
No, no.
every lab.
So that test is not to be done in routine clinical practice. As I said, this we are doing it free of cost at our center because we have a RCT going on plasma exchange versus steroids in alcoholic patients with ACLF.
But
So that
suppose
is
in
not
other center, sir, other center where this test
other
are
centers, what you see, the clinical parameters, if you see a patient who is in the ICU with encephalopathy, with a high creatinine, with a high bilirubin and a high INR, these are the four parameters which dramatically improve with plasma exchange. You see, so we had a patient yesterday with a tubercular ATT-induced acute liver failure. She was unconscious. Family says, we can't do a transplant. The transplant team says we can't even think of a transplant because there's an active COX. So we did a plasma exchange. So patient's sensorium has improved. The bilirubin has come down from 35 to 12. I know this is artificial lowering. INR has improved. So these are the parameters which you have to look in the bedside. We don't look at cytokines and endotoxins in the bedside because that is not practically possible. And that doesn't translate to anything if it doesn't improve the patient.
But any cutoff for bilirubin, INR, creatinine you are taking in your hospital, that this cutoff
No.
now you have to start, nothing like that.
So we don't go by bilirubin levels. We are more concerned about the INR. Patients who are encephalopathic, having high INR, are the ones which we push. We are used in patients, as I said, in pruritus. Some patients, yesterday there's another patient who had plasma exchange of hepatitis B. Bilirubin is showing as 48 or something, but he has intractable itching. His INR is normal. So this patient, we have tried everything for the last 10 days. So that is one patient for symptomatically, that is the different indications, but there's no specific cutoff. So we are not guided by only the bilirubin level.
You are more, it is a overall clinical scenario.
It is overall, if there is our most common indications are encephalopathy and high coagulopathy, which is not getting corrected. And most of these patients are usually in the ICU, majority.
Okay. Anyone wants to ask?
Sir, my question is, what is the difference in the routine dialysis machine Plex and this machine Plex?
No, this is the machine which is there in the, which we use in the blood bank to separate plasma. So this is not the routine dialysis machine. The routine dialysis machine, you can insert, there are a lot of cartridges available by some companies now, like bilirubin cartridge, ALF cartridge, but those cartridges we have used, but we didn't see results. So this is just a machine which is there in any blood bank where they separate plasma and blood products. It will be there in any blood bank. So we also don't have a separate machine dedicated for this. So most of the time we have 3 machines in the blood bank. They shift the machine. In one of them, they keep on doing these procedures. And you have to be very friendly with the blood bank person because they have to give you the plasma.
Okay, thank you.
Sir, is there any separate machine for hepatitis B, HIV, and patient with alcoholic cirrhosis?
So we have separated machines for Hep B and Hep C. HIV patients, to be honest, we have not done a single case. We didn't have such a case, at least in our center till now, who required plasma exchange.
So can this machine, I mean the process of plasma exchange be done with a machine like ECMO machine, like extracorporeal membrane oxygenation? We have that in Surat here, but can this be included in that? Because primarily they both function in the same way. We take out the
I
blood
think it
from the
should be.
patient.
I think it should be possible, but I don't know whether the charges will go up when you use an ECMO machine for this.
Similar, the cost
But
is
it
almost
should be
similar.
possible because the mechanism is same. You just have to put, there are 3 inputs of albumin. The mechanism is absolutely the same.
So the question to Saumin sir is it possible here in Surat, sir?
But Somin should be able to do it because this doesn't need very, once you do a few cases, it should be very easily done.
You see, basically, I feel Surat has enough potential to start this.
Okay, why I have included this? Because there are only few intervention which makes significant clinical improvement in the cirrhotic. One of this is plasmapheresis, and second we are going to discuss is intermittent albumin therapy in the last 2 or 3 years what we are seeing. So suppose we gain this knowledge, suppose we are willing, we can start, not right now, but if we are keen enough, okay, I think Surat, if we can start ECMO, how can't we start this? We can easily start this. Only thing, keenness is required, knowledge is required, and proper training is required.
Uh, hi, Dr. Mithun. Amit Mandotia from Global
Please tell Amit.
Mumbai.
Yeah, please
Hi.
tell Amit.
So I think the policy which we adopt, I think I would want your input also. Like whenever we see any severe alcoholic hepatitis or any autoimmune hepatitis related ACLF, we go by the MELD score. As in, if the MELD is less than 30, then we may attempt steroids. If the MELD is more than 35, then we think of an upfront transplant. Between 30 and 35, if there are organ failure, we will think of transplant. If there are no other or extrahepatic organ failure, then plasma exchange. Like that's the thumb rule which we kind of to simplify it for our unit. Yeah.
Yeah, so I agree with you, because see, all these papers that I showed excluded patients of alcoholic hepatitis.
What I feel is, sir, till is the case selection. If we don't have certain criteria for the case selection, and we have to just go by the clinical knowledge, that's why I think most of the otherwise this is not very difficult thing. Okay, but I think because of lack of knowledge and lack of because right now data is coming till and no a specific cutoff or something like scoring that absolutely we should start, and lack of knowledge. Many people don't know right now that the plaques can be used in the ACLF and ALF. So that's why it is not going on in Surat frequently. But we can start. There is nothing like.
We should start. Yeah.
We will need your help, sir. I will come there.
That's okay. But if you have an ECMO machine there,
yes, it is ECMO machine is there.
could have been
Surat
already
is a
there.
very rich city, sir.
Yeah,
They purchase anything.
yeah, right.
Guy,
What you need will be one good dedicated intensivist who can.
Yeah.
blood. You see, there are difference in the setup. Okay, you can't compare the every hospital setup with the AIG, where they can donate one machine to the ICU for apheresis. Okay, because their entire work, blood bank work has been hampered. Okay, yeah, 2-3 hours. But usually, I personally feel that they are not going to shift in any institute. Okay. That is AIG is altogether.
No, but it's a 30 lakh machine.
Yeah, you can purchase. That is
that's the
better.
MRP. So you will get it in 6 months, I think. From the business point, since it's Gujarat. Yeah.
Okay.
Right. Thank you.
Okay. Any other question? So, thank you very much, sir. And we will meet you next year. Okay, and hope you can come next year.
Sure,
Okay?
sure. Thank you so much.
Thank you. Thank you, sir.
Thank you.
So, now our next talk will be by Dr. Amit Mandut, sir. He is a hepatologist and director from the Global Hospital, Mumbai. And our talk will be the saraglitazar and obeticholic acid. Many times, please, sir, you take your presentation in pen drive, sir. Okay. Many times you are using saraglitazar, or people are promoting saraglitazar, obeticholic acid, but both of this drug doesn't have FDA approval. Why is it so? Why is it DGC approval in India and you can use in NFL in India only? So is it really useful? It's a marketing gimmick. It's a partially useful. So these are the two drugs which we have received in the last 2-3 years for the hepatology. So let's discuss these drugs and let's really it is useful or should we use it or not. Okay. And I am inviting, I am asking Dr. Harshil to invite the chairperson.
It's my great pleasure to welcome our esteemed chairperson for this session. Dr. Mukul Vyas sir, Dr. Chintan Patel sir, Dr. Nainesh Shah sir, and Dr. Ashok Shah sir. Please come on the stage, sir, for this session. Thank you. Thanks so much.
डाल दें। चलो। Yeah, am I audible? Yeah, thank you. So, thank you, Dr. Somin. And the topic for today is something I would say controversial, something which is upcoming, but very, very important, because this is something day-to-day clinical practice for all physicians, gastroenterologists, hepatologists, diabetologists, I would say even family physicians, because obesity and NAFLD is becoming it is already an epidemic in India. So there are 2-3 molecules which are available. I have been asked to speak mainly on saroglitazole and obeticholic acid, which are available. So I would try to give you what is the current data. Yes, I would say some of the data is biased, because finally what is published in literature is also driven by what research is carried out and who carries out the research. So we all know these issues are always there, but I would try to give an honest opinion as to what can be done or should be done in clinical practice, or what I would do in clinical practice. So first thing is always risk stratification in NAFLD. I won't go too much into details. I know Pathik is speaking on this, but whenever there is a patient with incidental detection of elevated transaminases, or patient with obesity, diabetes, metabolic syndrome, always check for fatty liver using ultrasound. And if there is any fatty liver evident, hepatic steatosis which is evident on ultrasound, in your clinical practice, day-to-day practice, look at AST, ALT and the platelet count. And that will give you an idea. If the AST is more than ALT, platelet counts are dropping, then you think that this patient may be having a little more than just fat in the liver. He may be having fibrosis of the liver because of this fat. So a fatty liver means only hepatic steatosis, but NASH means steatosis with inflammation with or without fibrosis. So I would give recommendation. Ultrasound is the first thing to detect hepatic steatosis. There is a strong recommendation. Once you feel that this patient may be elderly, patient may be diabetic, metabolic syndrome, AST-ALT ratio has reversed, low platelet, elastography is the first line investigation. A fibroscan or an MR elastography should be the non-invasive test for detection of hepatic fibrosis. Don't go by transaminases. It should not be used for judging the severity. If the enzymes are high, means the patient is having a severe disease, and normal enzymes means non-severe disease, no. A patient with compensated cirrhosis can have normal enzymes. So enzymes is just a rough guide, but don't use them to prognosticate the patient. APRI, FIB4 are the initial screening tools, and if the patients are having FIB4 which is altered, then get a elastography done. And then there are cutoffs of elastography which are self-explanatory. So how do we treat this patient? Coming to the treatment, first and foremost is this patient has to be treated as a whole. So control diabetes, hypertension, dyslipidemia, and that is very, very important. And that should be as per the standard recommendation. If statins are indicated, please go ahead and give them. Just because the enzymes are high, do not stop statins. If the patient needs a statin for dyslipidemia, please go ahead. And then coming to pharmacotherapy for NAFLD per se, most of the studies initial studies with vitamin E, pioglitazone were done with biopsy proven NASH, and then came saroglitazole and obeticholic acid. So currently we have 4 molecules which are there in our armamentarium: vitamin E, pioglitazone, saroglitazole and obeticholic acid. And nowadays semaglutide has come up, and that is also very, very important molecule, and I think it will play a very important role in the treatment of NAFLD in the future. So first thing is, all patients don't need therapy. If there is no fibrosis, if it is only fatty liver, then patient just needs lifestyle modification. Lifestyle modification is always going to be the key. If along with steatosis patient has hepatic fibrosis, which nowadays we judge non-invasively by fibroscan, then we should consider treatment. The choice of the drug should be individualized on the basis of age, gender. You have to see whether the patient is diabetic or dyslipidemic only or no, because there are certain molecules which will also impact the dyslipidemia, certain molecules which will worsen the dyslipidemia. So we have to take this into consideration. And there are certain molecules which will cause weight loss, certain molecules like pioglitazone which will cause weight gain. So we have to have these things in mind when we are treating the patient. So it's not just a random choice of molecule. We have to look at all these things when we are treating a patient with NASH or fatty liver. And in liver biopsy, where it is not available, we can go by non-invasive assessment, and that is what we are doing in practice. Pending further evidence, INASL, which is the Indian National Association for Study of Liver, suggests not using NASH-specific therapy with NASH cirrhosis. So if the patient has already developed F4 fibrosis or cirrhosis, there is no approved therapy. Well, that does not mean we do not treat. We treat, and I'll come to that, what we use. So as far as the national guidelines are concerned, they would go strictly by evidence. But then we know that in practice, we also go by some retrospective study, some individual data, some personal experience, and then we treat. So we treat even patients with compensated cirrhosis. Decompensated cirrhosis, there is no much role of NASH-related pharmacotherapy. So coming to saroglitazar, what is a saroglitazar? It is a PPAR, novel dual PPAR alpha gamma agonist. So it acts on the PPAR pathway, and with that, it decreases hepatic steatosis and insulin resistance. It decreases hepatic inflammation, and it decreases hepatic fibrosis. So basically, it improves the insulin sensitivity, and by that, it will reduce the steatosis, and it reduces the de novo triglyceride synthesis. So that is why if the patient is diabetic, also has hypertriglyceridemia, and patient needs treatment for fatty liver NASH, I would think of saroglitazar, because it would reduce de novo triglyceride synthesis and lipolysis. And with this, the endoplasmic stress on the hepatocytes go down, and there is decrease in hepatic inflammation. And once there is hepatic inflammation is reduced, the hepatic stellate cell activation is low, and fibrosis reduces. So this is the pathway, this is theory. What is there when it comes to the evidences? There are 3 important studies. These are called as evidences studies. One thing I would like to tell you with saroglitazar is none of the studies, large studies, have been published in literature which has been biopsy proven. So when it comes to obeticholic acid, when it comes to vitamin E, there is a study of say more than 500 patients where patients were randomized based on biopsy. Saroglitazar, most of the studies are based on non-invasive assessment. Well, that's fine, because you can always argue that in clinical practice also we are using non-invasive assessment only nowadays. There has been one study which was done by Dr. Duseja, Dr. Sareen, a multi-center study which was biopsy proven, but that study was never published. It was only presented as an abstract at an APASL conference. So if you look at these evidences, these were all small studies, non-invasive assessment, and one study which was biopsy proven, which met the primary endpoint of resolution of NASH. So NASH means inflammation. So with this study, which was a small study of around 20 to 30 patients biopsy in each arm, which was published, presented by Dr. Sareen, who is one of the leading hepatologists of the country in APASL 2020, it showed that saroglitazar met the primary endpoint of resolution of NASH without worsening of fibrosis, and it improved lipid parameters and improved liver parameters from baseline to week 52. So here saroglitazar was given for 1 year. So currently saroglitazar is recommended to be given for 1 year. This was another phase 2 proof of concept pilot trial where 16 subjects, again as I told you, very small data, with histologically confirmed NASH, were given saroglitazar 4 milligram, 2 milligram on placebo, and here there was a decrease in NAFLD activity score, which is a score on biopsy. So there was fibrosis improvement in 57% of patients. The ballooning, which is one of the hallmark of liver inflammation, vanished in 57% of patients, and NASH resolution in 43% of patients. So this was very good response which was seen. Mind you, no medicine in NASH resolves fibrosis in more than 20 to 30% patients. The best of pharmacotherapy, it causes resolution of fibrosis by 1 or 2 stages in only 30 to 40% of patients. The best results in NASH actually have been seen with bariatric surgery if a patient is obese and merits bariatric surgery. There the resolution of fibrosis is to the tune of 45 to 70%. So when we see a resolution of a decrease in fibrosis in 40 to 50% of patients, it is fantastic result. It is something which is good, because pharmacotherapy is only one of the arms of treatment. More important is diet, weight loss, control of regular exercise, and control of comorbid condition. So here it showed fibrosis improvement in 57% of patients. But in other studies, this kind of effect has not been found. So currently the decrease in fibrosis with saroglitazar is seen to the tune of around 20 to 30% of patients. It reduces hepatic steatosis in almost 60% of patients. So it is very good at reducing the fat and in reducing hepatic inflammation. So this is one study which was again phase 2 trial of saroglitazar, and here it showed that the decrease in ALT level, which is an indirect marker of inflammation, was very good. It significantly improved serum ALT. So many a times we start patient on saroglitazar, the enzymes are SGPTs 80, 90, 100. In 6 months it comes down to, in 3 months it comes down to 20, 30. Patients are very happy. And they feel, sir, ye band kyun karna hai? Why should I stop the medicine? It's working very well. And it's a dilemma. At times we do continue, because it reduces hepatic inflammation very well. But the primary endpoint for most NASH patient is reduction in fibrosis. Finally, the outcome or the prognosis depends on the fibrosis. But yes, inflammation is also an important pathway. Once you reduce the inflammation, the ongoing or the new fibrosis will reduce. So it is very good at reducing inflammation and reducing fat. Fibrosis, it is 20 to 30%. And here they have said that they used ALT and fat as a surrogate markers for reduction in fibrosis. So 30% reduction in fat would roughly translate to 1 stage reduction in fibrosis. Again, it is more of an assumption, not evidence-based. So if you look at the systematic review over the next, before I go to obeticholic acid, there have been 44 studies. Most of the studies are based on non-invasive assessment, 3,600 patients. The studies duration ranged from 12 to 52 weeks. 8 studies, there was significant decrease in the CAP levels. CAP level is a marker of amount of fat in the liver. On fibroscan, you get the CAP level. 2 studies showed significant improvement in hepatic steatosis on MR elastography. 27 studies showed significant reduction in LSM scores, which is a score which tells you about the fibrosis, the liver stiffness measurement. So in fibroscan, there are 2 values which are important. One is the liver stiffness. If the liver stiffness is more than 8.2, we should treat the patient. More than 13.2, patient is cirrhotic. Between 8.2 and 13.2, if we can get the values down, it is good. So 27 studies showed improvement in that. And there were only 2 histology-based studies which were less than 20 patients. It showed improvement in NAFLD activity score, but they were very small studies and they have not been published. So this is something which you need to keep in mind. So today, the place in therapy for saroglitazar would be, if the enzymes are high and you want, and there is, patient also has fibrosis, it will reduce the ALT by week 16 in more than 50% of patients. It will reduce the LSM, as I said, by 20%. So if you treat 100 patients, in 20% of patients, there will be a reduction in fibrosis. And it is good if the patient has associated metabolic syndrome or dyslipidemia, because it improves HbA1c and there is no risk of hypoglycemia. So it is a modest reduction in sugars. Also, it definitely reduces triglycerides. So if the patient is fatty liver with diabetic, with dyslipidemia, non-cirrhotic, with high enzymes, saroglitazole is the drug of choice. If the patient is very obese, then saroglitazole may not be very useful because it does not cause weight reduction. Then you can think of semaglutide, where you would also want weight reduction with semaglutide. But the evidence with semaglutide is still evolving. Most of the evidence is with subcute. I won't talk on that. And it can easily be combined with statins and other diabetic drugs. So this would be the current place in therapy of saroglitazole. So again, the patient profile which you should remember is NASH with or without hepatic fibrosis, diabetic or non-diabetic, obesity. You have to remember it will not decrease the body weight. It does not increase the body weight also. So pioglitazone, we are always worried about the increase in body weight. Dyslipidemia, metabolic syndrome, you can safely use in patients who have risk of prostate cancer, where vitamin E, which is one of the other drugs, there is a risk of prostate cancer with vitamin E. And post-menopausal also, it does not cause any worsening, which other molecules can. So these are the patient profile where saroglitazole can be used. What are the limitations of saroglitazole? The reduction in ALT is not a very robust marker, and it has not been shown to cause a significant improvement in insulin resistance. Role of saroglitazole only with high ALT without histological endpoints is always, we should keep our minds open and view it with a bit of skepticism. In 15% of weight see, this is a weak PPAR gamma agonist, and that's why the weight gain is not much. But in 15% of patients, there was some weight gain. So we need to keep that in mind. But in clinical practice, that's not much of an issue. 42 to 68% patients had diabetes at baseline in these studies. So we don't know how much the diabetic drugs were working, how much the diet was working. But then in real life, also 60 to 70% of our fatty liver patients are diabetic. So this, I would say, is not a very strong limitation. And in overweight patients with NAFLD, a 3-month therapy with saroglitazole is able to improve transaminases, but not LSM and CAP value unless there is weight reduction. So that is what. It also has to be combined with weight loss through other mechanisms or through other drugs. And that we need to keep in mind. Next 5 minutes, I would be speaking about obeticholic acid. It is an FXR agonist, where it reduces the amount of bile acids which are produced, and these bile acids are one of the sources of inflammation and fibrosis in the liver. So this was a large study, 2,500 patients, the Regenerate study, which was published in Lancet, where the patients were given, they were all histologically proven NASH. They were given placebo, obeticholic acid 10 milligram and 25 milligram. And the endpoints were fibrosis improvement and or NASH resolution, which is an inflammation reversal. And success at 18 months was defined as achievement of at least one of these two primary endpoints. So here we see that the primary endpoint of reduction in fibrosis was 23%, which, mind you, as far as all the data drugs which are available today, this is the best reduction in fibrosis which obeticholic acid had. But that reduction in fibrosis was seen with 25 milligram, which again was not at all very well tolerated. So there were almost 40% of patients who had some amount of adverse effects, predominant of them being itching. There were a few deaths also, but the deaths were not significant, even placebo. So there were some risks of sudden cardiac deaths also, but the most important thing was pruritus. And also some patients also developed pancreatitis and gallbladder disease, because it does not have a favorable effect on lipid parameters. So obeticholic acid is associated with an increase in lipoprotein levels, which improves after drug discontinuation or addition of statin. So if the patient is dyslipidemic, already having high LDL cholesterol, obeticholic acid has to be used with caution. because it will further increase the LDL cholesterol level. So there was an FDA. So the results were good in the sense obeticholic acid does not reduce much of inflammation, it does not reduce fat, but it reduces the fibrosis quite well. Though you would say 23% is not great, but as I've been again and again reiterating, no molecule has a better fibrosis resolution. So the best is to prevent the progression of fibrosis. We may not be able to reverse much. So it reduces, so it's a good antifibrotic, not a good anti-inflammatory, not a good anti-fat molecule. But the problem is side effects. And there was a FDA panel which voted on obeticholic acid whether to use or no for pre-cirrhotic fibrosis due to NASH. And what the FDA panel voted was against using it. So currently it is not much used. I don't think most gastroenterologists or hepatologists use it in their practice. One, because of the unfavorable side effect profile, and the other is the dose which has been recommended is 25 milligram, which is not, we are all worried about the side effects when using that. There are some centers which I am aware of which are doing certain studies, prospective studies on obeticholic acid. So let's wait from real world data from India. But as of now, even the US FDA voted against it, and we don't use it much either. I don't think it has no role in therapy. If we want resolution of fibrosis as an add-on molecule, it may find role if we can get the right dose where the side effects may be easily tolerated. But as of today, we don't use it in clinical practice. I think I've already suggested this is the INAZL recommendation. So today, if you go by the recommendation of the Indian National Association of Liver Disease, saroglitazole is recommended as pharmacotherapy for NASH with or without hepatic fibrosis in both diabetic and non-diabetic adult population. But the recommendation is weak. Why? Because the evidence is not based on randomized controlled biopsy proven studies. So yes, it is approved by the Indian National Association. It is only approved by DGCI. The rest of the authorities, the drug regulatory authorities world over have not. But the Indian drug control DGCI has approved it, and it has been also approved by the INASL. Pending further evidence, INASL suggests not using obeticholic acid as pharmacotherapy. So currently, routine use of obeticholic acid should be avoided unless we have more data and we find the right kind of dose for our patients. So the only DGCI approved pharmacotherapy in India is saroglitazole. It is recommended for management of non-cirrhotic NASH for minimum duration of 1 year. But again, no randomized control trial, and INASL does not recommend use of obeticholic acid. To my mind, I see fatty liver being treated like how blood pressure is being treated, like how diabetes is being treated. It will need a combination of therapy. We will need molecules to make the patient lose weight. We will need molecules to reduce the inflammation and fat, which is saroglitazole, very good. Molecules which will have some impact on fibrosis, like obeticholic acid. So it probably would be a combination therapy, like how you all use combination for hypertension, for diabetes. I think fatty liver is going to be treated the same way in the near future. And there are some studies where combinations are also being used. I think for want of time, I won't go into that. Another drug which would be is weight loss, because as I said, if you look at all the evidences in fatty liver, the best results are with bariatric surgery. Before the patient develops portal hypertension and severe cirrhosis, if the patient can lose weight with any form of therapy, and bariatric is the best way to lose weight, they show the maximum improvement in inflammation and fibrosis. And that is why semaglutide will probably be a molecule which may have. So as of today, I think saroglitazole is a good drug for the patient profile which I just mentioned. Obeticholic acid we are not using in clinical practice. Thank you very much. SGLT2 inhibitor, again, since the topic was, so SGLT2 inhibitor is another class of drug which is found to be very useful. So currently, there was a paper which was published, which was presented at the American College of Gastroenterology, where they showed a retrospective data of SGLT2 inhibitor in diabetic population with cirrhosis, where they used, and it reduced the complications of cirrhosis, and it reduced the decompensation of cirrhosis. So SGLT2 inhibitor also, because of its ability to lose weight and control diabetes, yes, it's a molecule, but it has not been specifically studied only in fatty liver. It's a good molecule for fatty liver disease with cirrhosis or with diabetes as an anti-diabetic drug, but it has not been studied specifically for fatty liver. Though, as I mentioned, this retrospective data of almost, they took the entire database, the American, they have that database, and it was almost 10 to 15,000 patients, which paper was published in ACG. Sorry?
Duration of
The
treatment.
current recommended duration is 1 year. If I ask, if I ask maybe Pathik or Saumin or Gunjan, maybe, I think a lot of us, we keep on using it. Sometimes it's patients, because see, when the patient sees a definite reduction in AST, ALT, they feel happy, and when you stop the molecule, again the numbers go up. So at least in my practice, I have used it for more than 1 year, and I use a recommended duration because the studies have been carried out for 1 year. But we know that it's a safe molecule, there are no major side effects, and we know that fatty liver is not a definite disease which will end after 1 year. It is a continuous metabolic profile which is damaging the liver. So that is why with that logic we treat it longer. But if you go by evidence, it is 1 year. Vitamin E 2 years, pioglitazone studies are 2 years, the saroglitazone 1 year.
Do this patient,
Sorry?
do this patient after 52 weeks they have stopped saroglitazone?
Yes.
Have we studied all those patients in follow-up? What has happened to their NAFLD and NAS?
We haven't. That's a very relevant and a very good question, because if we stop at 1 year and we do a follow-up study, we don't have that data. But if we go by a logic of, say, obesity surgeries, bariatric surgery, as I said, it showed 70% resolution of fibrosis. After 5 years, almost more than half again had fibrosis. So we know that metabolic syndrome doesn't end with anything. So a lot of patients, if the therapy is not continued or if the lifestyle modifications do not continue, if their metabolic milieu is not changed, they will continue. So that is why I feel it's a long-term therapy. We go by evidence, which is because of the test, but it's a long-term therapy. And I can use the logic of bariatric surgery where they have had follow-up data. With saroglitazone, with vitamin E, we don't have follow-up data.
It is,
Sir.
No, I think we are, sir. We don't check our weights. And we feel we are not, and we are in fact, we have central obesity. So the concept of visceral fat is gaining more and more important, not just and I think the cutoffs of obesity for our population is lower.
you see, sir, no, sir, basically, if you
Yeah.
ask for the indication for bariatric surgery, in this case, indication is not only weight. It doesn't mean that you have to be 130, 140 kg to go to the bariatric. In this case, it is amount of the inflammation and fibrosis. If it is a significant inflammation and fibrosis, significant weight, significant inflammation and fibrosis, even at the weight of 90 or 95 kg, and if you are not going to reduce it despite of all your effort, even at 10% of your body weight, it is better to operate a bariatric, any procedure.
Yeah.
Even if it is an endoscopic procedure, you have to reduce at least 10% of your weight to at least achieve a subside, at least achieve a good reduction in the inflammation. So even if you are a 90 kg, you have to reduce a 9 kg, and if you are not going to achieve it, and you continue to remain 90 kg and your SGOT, SGPT and fibrosis marker remains like that, it is better to opt for the weight reduction any procedure.
Completely agree. Weight reduction is the key. How you reduce weight is not important. Sustained weight reduction is important. So there have been various diets, there are these molecules which are coming up. So when we think of bariatric surgery, it's not only the gastroileal bypass. There are many other bariatric procedures where the weight reduction is not so high. You need to reduce 10% of the body weight. And if you can do that, 45% of the patients will have decrease in fibrosis, half the patient, which none of the molecules have. None of the molecules available today has a 50% reduction in fibrosis.
Hello.
So weight reduction is a key. But there is a lot of population of lean NASH. There is a lot of population, as Dr. Saab mentioned, there are some patients who are not obese, but they still have metabolic syndrome. I agree. So drugs will be important for them, but even for them, it is a visceral fat which is harmful. So they need to change the composition of their body. Cut down on carbs, have more proteins. They need to reduce their fat with muscle. So they don't need to reduce weight, but the composition of the body has to change.
It is just like metabolic syndrome, sir. Even a young lean patient have MI. Young lean patient have a NASH. That's why single molecule is not effective. That's why lifelong treatment is required, because it is a basically problem with the metabolism. Okay, once you stop antihypertensive, BP will shoot. Once you stop any, because it is not a single molecule which we are going to target. It is a multi-hit at each and every organ of the body.
Hello, sir. Sir, you said that you have to use the saroglitazar for a minimum 1 year. That is true, and if the patient is responding by parameters, then you can continue. My question is, the patient is non-diabetic, because saroglitazar is still is not a cheaper molecule. So would you judge whether to continue beyond 1 year, or you can
I think
stop
based
it?
on the evidence available, if we can, in a non-diabetic, if the patient is having fatty liver, we use it for 1 year, and in that 1 year, if we have emphasized the importance of lifestyle, if the patient is adhering to lifestyle, then we can stop at 1 year. So we use, that does not mean it should be. If in that 1 year the patient has to be told the importance of a good lifestyle, and if the patient doesn't have advanced fibrosis, then we can stop the therapy.
Would you judge that within 6 months, if you have done the fibroscan and
Yes,
the patient
and
is
we
not
can
responding, then you can stop?
Yes.
Okay.
So as I said, 1 year is not some sacrosanct, it's not some, this is just the studies were done for 1 year, that's why we are saying 1 year. Otherwise, for some patients you continue, and some patients we can stop. There are patients who are very, very compliant with weight, and they really go on a good lifestyle change, and they don't need therapy. They will just improve. So as I've been saying, all these molecules have a huge placebo effect. All these patients are also losing weight, they are also controlling diet. It may completely be like a placebo, we don't know. These molecules may completely be like placebo. It may only be the lifestyle changes which is actually helping the patient. But then there is no real way. So yes, the studies have shown this is beyond lifestyle. I'm not saying it is like it's like placebo, but the benefit of lifestyle modification by itself are huge. That is the take one. Weight loss of 10% if the patient is obese is the most important line of therapy. And then if there is fibrosis, you add on molecules. If there is no fibrosis, only lifestyle modification. Is an equally. I told you the data from bariatric surgery. We have 5-year data from bariatric surgery of almost close to 40,000 patients. More than 50% had similar fatty liver kind of problem because they put on weight again. So it's not easy, but that's most important.
Hello, sir.
Hi.
I want to ask, at present, we are getting increasing number of pre-diabetes as well diabetic patients, like a epidemic, and we also finding the similarity increasing in NFLD or NASH. So do you feel that there is any correlation or anything that is in between these two diseases, or it is just overdiagnosis of NFLD, which is because of easy availability of various diagnostic procedure, non-invasive?
Yeah. So it's not overdiagnosis, it is fatty liver. If it is seen, it is there, What is important is every fatty liver you need not be worried about. And there is a definite correlation. The pathway of fatty liver and pathway of diabetes are similar. Insulin resistance is the key even in fatty liver. So definitely there is a correlation between diabetes and fatty liver. There is no doubt about it. And 60 to 80% of patients with fatty liver are either pre-diabetic or will be diabetic. It's not overdiagnosed, but every fatty liver need not be. So 30 to 40% of adult population of India will have fatty liver on USG screening. That does not mean only 5% of these patients will die because of liver disease. But what is important is these patients are prone to metabolic problems in the future. So actually I would say rather than being alarmed at and thinking it's an overdiagnosis, it should tell you that this patient 10 years later may develop diabetes, may develop hypertension, and that would be a bigger killer than fatty liver. So you need to institute lifestyle at that age of 20, 30, 40 when he comes with that fatty liver. So fatty liver is not an overdiagnosis. It should not be worried about in all the patient, but it should trigger the lifestyle change in that patient because he may develop cardiovascular and diabetes, which are much more morbid and mortality risk than fatty liver.
So that means if we early diagnose NFLD or NASH, there is a probability of preventing diabetes if by the lifestyle modification or either pharmacotherapy.
Yes. So NAFLD is considered as a precursor to diabetes in some studies. It's not a definite association which has been proven that they will all, but yes, it could be a precursor, and I would think that for all physicians you should consider fatty liver as a 6th arm of metabolic syndrome. We all know the 5 arms of metabolic syndrome. This may be the earliest arm because it's very easy to diagnose. And before the patient develops diabetes, yes, if the patient has fatty liver, you need to make the patients aware of the possible problems in the future. No, not in each and every. So if the patient is more than 45 and patient has fatty liver for quite some time, if the patient has comorbid conditions like diabetes and dyslipidemia and more than 40-45, or something which is very simple which you can do it in your clinic is FIB-4 score. I think Patik, you will be speaking on FIB-4 score. Dr. Patik has a talk on that. Very simple. You just look the ratio of AST, ALT and the platelet count and you can do it. If the FIB-4 is a very good screening modality in clinic. So if that is deranged, you do fibroscan, but not in everyone. You can. So if the FIB-4 score is more than 2.7, that would suggest the chances of significant fibrosis. It is not as the association correlation is not as strong as fibroscan, which is the fibroscan, the area under the curve is almost to the tune of 90%, but FIB-4 is also 80%. So 80% chances that you will be right based only on FIB-4. So which is, if it is not available, yes, go by FIB-4 score. If the FIB-4 score is more than 2.7, it is significant fibrosis, and 80% chances that you would be wrong. 20% chance that you are probably overdiagnosing.
Okay, we are slightly running out of time, and I will ask Dr. Mukul to felicitate Dr. Amit sir. And a big round of applause for Dr. Amit sir. He has to shift his house today. Okay, but because of his commitment, he came. So thank you very much, sir. Okay. Now I am going to invite Dr. Pankaj Puri. He is my PG teacher and he will remain my teacher throughout my life. Whatever I learned gastroenterology is everything from him. He was in army hospital and served in the armed forces, and right now he is working as a gastroenterologist. in private practice after taking release from the army hospital. So intermittent albumin therapy is I think one of the very good intervention right now you can use in your practice. I am using in my practice, and definitely it will reduce the hospitalization as well as the optimize the patient during the waiting time. So we will learn more about this from Dr. Pankaj Puri sir. Thank you sir.
Thank you, Dr. Somin. Thank you, everybody. It's always a pleasure to come to this city. Treatment of medical liver disease is always expensive business. Liver transplant is expensive. I mean, they all work. Anything which works is expensive in the liver. Look at plasmapheresis, plasma exchange, it's expensive. Amit has just spoken about Ribelsis, or that is the new semaglutide. That costs 10,000 rupees every month. Similarly with albumin. Albumin therapy is expensive. We know that the liver forms albumin, and when there is significant liver disease, the albumin will fall. And it stands to rationale that giving albumin will make the patient better. But the problem of giving such expensive drug is that is it really making a change, and should we give it? If it was not for the cost, probably the debate would not be as much. Albumin has both oncotic as well as non-oncotic values. We all know that it changes the oncotic pressure and helps in fluid control. But along with that, it also has an antioxidant effect, an effect on homeostasis, immunomodulation, endothelial stabilization. So it has many anti-inflammatory effects as well. So the effects beyond just volume control and helps in control in infections. So patients with cirrhosis have low albumin, and the albumin, not only is it low, but it's of poorer quality. So patients will, when we give albumin, we restore the oncotic pressure, we increase the effective blood volume, we have improvement in kidney perfusion, improvement therefore of renal failure. Besides this, it has anti-inflammatory effects, and we have effect which will help in patients who have sepsis. These are the standard recommendations of giving albumin. One is large volume paracentesis. If you're going to remove more than 5 liters of ascitic fluid, then you give albumin replacement at 6 to 8 grams per liter. So normally we will have 20 grams in 100 ml vial. So if we're going to remove about 6 liters, we'll end up giving 2 such vials. Second is, it has been recommended in management of SBP. But again, while we don't use these large volumes routinely, the recommended doses are about 1.5 grams per kg on day 1 and 1 gram per kg on day 3 after diagnosing SBP. This has been shown to improve mortality. The diagnosis of HRS to rule out volume depletion. If the patient comes with low volume, low urine output, and the creatinine is going up, he could be volume depleted. So you give albumin as a challenge to see if that is going to improve the renal functions. And lastly, albumin is used in management of hepatorenal syndrome, and we give infusion at about 20 to 40 grams per day along with vasoconstrictor therapy. So efficacy of albumin treatment for patients with cirrhosis and infections, which is unrelated to spontaneous. So in SBP we know it works, but here was a study which was looking at infections other than SBP, and they gave the same doses as they gave in patients with SBP, but the mortality difference was not there. There was no improvement in mortality. They had some improvements because some people had ACLF improvement, but at the same time they had lower nosocomial infections, but again mortality difference did not. So if you have infection and you think you're going to give albumin, it won't work unless this is a ascitic fluid infection. This is a list of all the short-term trials which have been done for treatment of bacterial infection, and people have used different doses, but these have not shown to have any significant improvement. If you see, look at the bottom, 3 months survival unchanged, 3 months survival unchanged. So there's really no benefit on short-term therapy. This was a important study which came out. This was a randomized trial of albumin infusion in hospitalized patients, and they called it the ATTIRE trial, which is albumin to prevent infection and chronic liver failure. They had about more than 700 patients, and they gave albumin with a target of raising the albumin beyond 3.5 gram per liter for 2 weeks. They found no benefit. But some of the reasons of these negative results was that they gave a lower dose of albumin. And second is there were some limitations in design. The patients had infection, they were sicker patients. They gave for only a short time, only for 2 weeks. They excluded all patients with ACLF who may have had benefit. Also, the control arm received albumin, and this came along with a editorial which said albumin infusions and decompensated cirrhosis is no longer the elixir of life. But overall, in short term, unless you're treating spontaneous bacterial peritonitis or treating hepatorenal syndrome, there's no role of giving albumin on short term infections. What about long term? Many of us, including me, are using albumin infusions for control of ascites, patients who are decompensated. So what are the studies on them? So there were 4 such major studies. The one on the first 2, which is the ANSWER and the MASH trials, were important studies, but they were totally diametrically opposite results. Now let's just look at these trials. The MAC trial had slightly worse MELD scores at the baseline. The amount of albumin given in ANSWER trial was higher. They gave 40 grams initially, twice a week, and then they gave 40 grams once a week. That means 2 vials weekly. The MAC trial did not give any induction dose, and they gave the same thing once a week. The length of study was much longer in the ANSWER trial. The outcome was that the ANSWER trial showed improvement in mortality, while the MAC trial did not. So if you look at this ANSWER trial, this was the ANSWER trial, and it was a short acronym for albumin in the treatment of ascites. And the first 2 weeks they gave twice a week, 2 vials each. That means 4 vials in the first week, and then 2 vials every week for 1.5 years. And the albumin group had better survival, and the mortality decreased by 38%. There was decreased need for paracentesis and decreased occurrence of resistant ascites. And there were obviously overall benefit in these patients with SBP, HRS, and encephalopathy. This was the second trial, which is the MAC trial. They had some improvement in plasma renin, but the arterial pressure and the cytokine levels did not show. There was no difference in mortality between these 2 trials. As I said, there were 2 problems. They gave only about half the amount of albumin was given compared to the ANSWER trial, and no loading dose. Also, secondly, the patients had more advanced disease. So probably, if you look at the ANSWER trial, they had earlier disease, they were not such advanced disease, and probably that's one of the reasons they improved. And the second reason was they gave more higher doses of albumin, and that was important in making these patients better. Sorry. What should be the target of albumin level? We keep giving albumin, what should be the target? So if we looked at the ANSWER database, the improvement did not happen until it crossed 3.5 grams per liter. And the levels you reach after 1 month of therapy is what is going to make these patients show whether they're going to have a survival. And the best discriminating cutoff levels was if the albumin was more than 4. So you get your albumin levels up to more than 4 and give them a little early before they advance disease, and that is how they will be better. So the target should be more than 4, but there's no exact well recognized data as to this should be the target we should have. It's not just sometimes only about the albumin levels. It is also about what is the effective albumin level. This albumin is defective. The albumin undergoes translational changes, so it doesn't remain as good. So if you can measure the function of albumin, which has been done by various ways, and I'll show you a study which showed that, then the effective albumin concentration may be lower. So it could be a better marker of what is the albumin to use. Now there have been a couple of meta-analyses using all the trials which have been done. So this was one meta-analysis which included 42 randomized controlled trials. And they showed that it would decrease the mortality in SBP and hepatic encephalopathy, but not in ascites and non-SBP infections. Overall, if you look at all the studies, they did not show decrease in long-term mortality. Why do I say that and I still go ahead and give albumin? Because this was a mix of all studies which had early and late disease. It has a mix of all studies which was lower and higher doses of albumin. So if you have a patient who's still early, his quality of life will be better. So giving albumin is not just about decreasing mortality. It's also about improving his quality of life. If the liver disease is far advanced, no amount of albumin is going to make him live longer. You have to control his ascites and make him better. So if you look at this, I don't know if it's visible from there, if you look at the top, this was comparing albumin versus no albumin, and look at overall mortality. There was a benefit, but the benefit only came with higher dose of albumin. The lower dose of albumin did not show any benefit. So recurrence of ascites also improved, and obviously when you do paracentesis, then post-paracentesis dysfunction and hyponatremia, these things also improved. So spontaneous bacterial peritonitis is another issue where it improved in patients. We have to, however, when we give albumin, consider the adverse effects and the cost considerations. There are allergic reactions, volume overload, coagulation derangements, and 3,500 to 4,000 is the cost of albumin, depending on what you buy. And that's going to be about 4 lakhs a year if you're going to give regular albumin in the recommended doses. A cost-effective analysis of long-term albumin infusion needs to be done in different settings, especially in developing countries where the cost is borne directly out of pocket by the patients. So I was discussing about effective albumin dose. So this is a study where they looked at the total TALB is the total albumin, which is standard the way we measure it, and E-albumin is the effective albumin, which is measured by liquid chromatography, electrospray, and many advanced methods. And then after doing that, they found that the binding and detoxification efficiency was different. So the effective albumin is really what defines it. It means that you may have a value which is showing you 3, 3.5, but may not be the greatest albumin. So short-term albumin could reduce the short-term mortality in some patients in specific diseases like spontaneous bacterial peritonitis. Not going to improve in diseases like patients who have, say, infections because of pneumonia. It's not going to be improved in that. It's going to improve the hemodynamic status and the systemic inflammation as well. The long-term outcome is closely related to progression of cirrhosis. And long-term infusion should have logistical and cost issues, which may pose a challenge to its wider application in clinical practice. The current evidence is inadequate to recommend across the board, but we see what reason are we giving it for. If we are giving it for control of ascites, definitely we should give it. We just don't go by saying the data is not enough. We have to raise the albumin levels adequately. We get the albumin levels close to 4 and beyond, they'll be better, and control of ascites will be better. What would I do? See, cost is an important issue, and we can't turn it away from the patient. we have to see the patient population. Is he a transplant candidate? How much is his ascites, and what is his capability of spending that amount of money? I think you make a decision keeping all these things in mind. If ascites is significant, cost is not too much of a deterrent, you should give albumin. And we would start off by giving 1 to 2 times a week, drop it to weekly, and practically drop it to once a fortnight, and depending on what how much ascites there is, probably come down to once in about 3 to 4 weeks, because cost cannot be ignored. I think with that I'll close my slides, and thank you very much. That's our team, and that's Dr. Acharya in the middle, and that's the 5 of us. If there are any questions, I'll be happy to take them. So it's the same principle in all sources. You're looking at two things. You're looking at systemic infections, which are like SBP. You're looking at volume depletion and resulting hepatorenal syndromes, and control of ascites. So whatever the etiology be, albumin needs to be considered. The current data says it's not going to improve mortality. Yeah, but the liver disease is far advanced. You won't have data on that. But the comfort, the control of ascites, these are not quantifiable. So the half-life of albumin is about 3 weeks, but ascites in liver disease, the albumin changes, it gets modified, may not be as effective. So practically, the effect may not last as long as 3 weeks. Infusion rate needs to be slow. The reason for this is twofold. First is volume overload, and you can have pulmonary edema. And the second is allergic reaction. So you should give it over not less than 4 hours. So generally 4 to 6 hours, slow infusion. So if effective albumin level is by by advanced tests which are not routinely available. It's just the concept I'm introducing you. We don't have those tests routinely available. But what I'm saying is your values which you see in the lab may not reflect the actual effect of the albumin going into the patient's body.
Regarding the etiology and the work, once burned out cirrhosis happens, once there is a child is C cirrhosis, and if you treat the primary etiology, suppose patient has a hepatitis B, C, he is already on antiviral for 6 months, okay, and alcohol has been stopped for since 6 months until he or she remains in the child C status, then almost all managements are same, because there is no viable liver or there is no ongoing inflammation. Okay, so either you treat a HRS, ascites, SBP, everything guidelines remain same. But the important thing is the improvement in the short-term mortality. So those patients who are in waiting time for cadaver transplant, they are greatly benefited. And second is the quality of life. If you use in your clinic, you will see the number of the hospitalization will reduce. So that is I think greatly impacted by this intermittent albumin therapy.
We wish we could give more of it than we routinely use, but it's expensive. You look at the doses which are recommended in SBP, 1.5 gram per kilogram. For a 60 kg man, that's about 90, that's about 4 vials. And 4 vials is a lot. I wonder if anybody is actually using this. How many people are actually using it? Are you using it? None of us use those doses because we know that the patient, we know patient will die, but he also die with taking his full wallet out.
But if suppose, sir, anybody is going to infuse 4 albumin per day, this patient usually has a compromised renal function also. So I think volume overload is I think much more what we, even if we see with the 1 or 2 albumin per day, we can see the volume overload in such patients.
So that will be just 10 ml per hour he'll
Yeah.
be going continuously. 10-15 ml per hour, that will be a continuous infusion over 24 hours.
Till we are going to infuse only 2 vials because 100 ml vial.
So,
So if 4 vials we are going to infuse, so I think in the cardiac compromised patient or a renal compromised patient, it may be possible the volume overload will be very high.
true. Those are concerns. So we have to watch that closely. The recommendation is 1.5 milligram per kilogram. That's a lot of, but we look at the dry weight.
So I asked Dr. Rajesh Mistry sir, okay, to felicitate Dr. Puri sir, and thank you sir for your precious time. Now we are going to have a break for the lunch. Okay, you can discuss your question in between lunch. Okay, I have deliberately kept 30 minutes because usually we are used to run late by 30 minutes in conference. So I just kept 12:30 to 1 p.m. is window period. Okay, so we are on time. Okay, you can take your lunch, you can discuss, and we will reassemble at, rather than 2, we will reassemble at 1:45. Okay, so we can discuss few more things during that period. Okay, thank you. Thank you. Hello. One announcement, there is a body composition analysis machine outside. If anybody wants to know their muscle mass or visceral fat, they can do it right now because it has to be done at least 3 hours empty stomach. Lunch can sit, and those they can continue with their lunch, but the one presentation we avoided at that time because of lack of time. We can complete it within 15 minutes, and I hope within 15 minutes all the delegates will complete their lunch and can join in the conference. And after 15 minutes, Dr. Gunjan Joshi from Rajkot will tell the jaundice is not just hepatitis. Jaundice is much more than hepatitis, and how we are going to evaluate on the OPD basis. So next, our 3 or 4 lectures are more directed towards your OPD practice. The initial lecture was more like a indoor patient, but now next 3 or 4 lectures will help you to improve your OPD practice. So that's why where we left indications for ascitic tapping. Okay, so ભાઈ આ PPT આમાં રન થયું કરજે ને દેખા દો. Indication for ascitic tapping. આપણે ascitic tapping ક્યારે કરવું જોઈએ? Okay, so basically it may be a diagnostic indication or therapeutic indication. Okay, so what I see in the practice is unnecessary therapeutic tapping and avoidance of the necessary diagnostic tapping. Why? Because PPT please. Because whenever a patient came to you with moderate ascites and ask pani pachu bharai gyu che. Okay, you ask your assistant, okay, we are going to remove it, remove 2 liter. That is not an indication for therapeutic tapping. Okay, so what are the indications for therapeutic tapping is first of all the respiratory compromise. Okay, if person is dyspneic or breathless purely because of compartment syndrome and tense ascites, then and then you should go for therapeutic tapping. Okay, and another thing is refractory ascites. Now in refractory ascites there are also 2 parts. It may be a resistant ascites or it may be a recalcitrant ascites. Now what are the maximum dose of diuretics we should give to the cirrhotic? So usually we are using a lesilectone 40 milligram or a diuretic furosemide 40 milligram. Okay, but maximum dose we can give of furosemide is 160 milligram per day and aldactone is up to 400 milligram per day with salt compliance. Okay, so all these 3 parameters is achieved, and despite that patient have ascites, then and then you can tell as a refractory ascites. Now what is the practical problem? This is definition. Most of the patient are not able to tolerate such high dose of diuretics. Okay, they usually develop a kidney injury, prerenal azotemia, hypotension, giddiness. So what we do, we try to use a furosemide maximum 80 milligram or a torsemide up to 20 milligram and then says okay, now we have to tap. Okay, so if side effect develops, then it becomes a recalcitrant ascites. Suppose you are, but before stamping it a recalcitrant, you should give a trial of incremental dosage. Dietro 10/50 માં ચાલુ કર્યો હોય એનાથી 20/50 એ ચાલુ કરીને જોવાની, and if they develop side effect then hold and stamp it as a recalcitrant ascites. So when there is a refractory ascites, you should go for therapeutic tapping. For the diagnostic tapping, any cirrhotic presented to you with ascites first time, you should go at least for the diagnostic tapping. That is also we are lacking in our practice. USG suggestive of cirrhosis patient with ascites, LFT suggestive of ascites, cirrhosis, CBC suggestive of platelet thrombocytopenia, liver fibrosis, and you stamp you have a liver cirrhosis with ascites, you start diuretics and you write the treatment. But at that time at least first diagnostic tap is mandatory, because many of these patients may have a mixed ascites. You have to calculate the SAG ratio. Then suspected SBPA or secondary bacterial peritonitis. Now in clinical scenario what happens, suppose patient came with the fever, we start antibiotic, admit him and start antibiotic. But ideally we should go for the ascitic tapping prior, particularly in the child C status and huge ascites. If we go if we want to manipulate, we can manipulate little thing. If it is a child C status and it's a gross ascites and patient presented with the fever, then you have to do at least a diagnostic tap, because chances of SBP is high. Okay, so when you diagnose this fever is of the SBP, or fever may be due to of the LRTI, but SBP is there, then you have to keep the patient on lifelong antibiotics. So this will help to reduce the recurrent infection later on, and you can promptly ask the patient when SBP developed sooner or later. If your etiology is irreversible, suppose patient develops SBP and is hepatitis C positive at that time untreated, and if you treat them, then there is a high possibility that it will reverse. Okay, but if it's a burned out cirrhotic, then you have to ask them that sooner or later you will require transplant, and you have to optimize that patient, put in a waiting list if donor is not available. Okay. Albumin already has been discussed by Puri sir, so I am not going to discuss. In SBP, you have to keep a third generation cephalosporin, or even ampicillin is good enough if you are going to use in the practice, but you should give a lifelong antibiotic. Even if it is a cyclical, it's a cyclical. Another important thing what we are looking, if ascitic fluid protein is less than 1 gram per liter, suppose you do a diagnostic tap, at that time it was not SBP, but ascitic fluid protein is less than 1 gram per day, 1 gram per deciliter, till that patient has a high chances of developing SBP. In such a case, you can put on a prophylactic antibiotic also. Underuse and overuse of albumin, I am not going to discuss it, okay, because we have already seen in the lecture of albumin. But if you are going to tap more than 5 liter, then you should give at least 6 gram of albumin. If you are going to tap 1 or 1.5 liter, albumin is not very mandatory. Okay, other rehydration method or plasma expander method can be used if you want to cut a cost. Now this is another thing what I have noticed in the practice. When you see the hyponatremia, cirrhosis, ascites, and you start 3% of normal saline. Now that is very unfortunate, because this is a hypervolemic hyponatremia. So at that time the treatment will be the fluid restriction. Okay, so at that time don't start 3% saline, it will aggravate the ascites. You give 3% saline, on one side you ask the patient for the salt restricted diet, on second side you are going a 3% normal saline. So you are infusing sodium and you are asking them to restrict the sodium orally. So this will lead to the increase in the ascites. So unless and until you are very sure that this is not a hypervolemic hyponatremia, then don't go with the 3% saline. Again, be sensitized with the kidney injury in the cirrhosis. Now what our mindset is, any creatinine less than 1.5 is okay. This is our routine mindset during the practice. But suppose some patient with the cirrhosis and creatinine is 0.8, you start diuretics, and after 3 or 4 days creatinine is 1.2. So it is a significant jump in his case. In such a case, you ask the patient to come after 5 days again, rather than giving a diuretics for a month and tell come after 1 month, and later on patient comes with the kidney injury and high creatinine. So be sensitized with the kidney injury. So it is a serum creatinine increase in more than and equal to 0.3 milligram per deciliter in 48 hours. In cirrhotic patient is also considered as a kidney injury. Third is the incidence of HCC in a cirrhosis. Now I telling one of my patient in the HCV cirrhosis, his wife had a cholangiocarcinoma. Both were my patient. Pre-COVID treated child age status. Okay, HCV treated child age status. Absolutely nothing, healthy patient. So I advised him to go for 6 monthly this test. We have proforma in our hospital that 6 monthly you have to do this test, yearly you have to do this test, 3 monthly you have to do this test. But somehow I feel I failed to emphasize that this is mandatory. Even if you are okay, you have to go for it. In that time COVID happens. So patient came after 2 years post COVID and say I am okay till now, but just go for one entire body profile, and at that time we find a 4 centimeter HCC, asymptomatic patient. Okay, so 6 monthly sonography and alpha fetoprotein, you should emphasize when you tell that this may happen even if you are asymptomatic. HCC with NASH, HBV, HCV may happen even you are not cirrhotic also. Okay, so 6 monthly surveillance, you should ask the patient and you should emphasize slightly that this is the reason why we are telling you to go for 6 monthly sonography. So this is a recommendation. Another thing we are lacking, even sometimes we are also avoiding, that the diagnostic endoscopy at the time of presentation of cirrhosis, even if it is a child A status. If you see the data, 30% cirrhotic patient have a varices which increases at the 90%. Okay, and prevalence of the high risk varices in the child is around 8%. So if patient is a child A status, LFT is relatively normal, sonography is just cirrhosis with portal hypertension, usually our approach is don't go for endoscopy. It is okay, it may take time, but this is not the true. If you go via guideline and patient is affording, we have to give them an option of endoscopy. Sometimes I am also avoiding because of the patient's financial condition and unnecessary questioning, because it is a relatively invasive, I cannot say it's a invasive, but I cannot say it is not a purely non-invasive test also. Okay, so patient usually say कि साहब endoscopy शू काम करावानी. Okay, I don't have any problem. This is just a sonography finding, but you should know, you should give option. Ideally, you should go for endoscopy because 8 to 10% chance that you have high risk varices and you may bleed. 90% chance your report may be normal. Okay, so at least write on paper, explain the patient. If he is willing, go for endoscopy. Another thing is, even patient is in the child B or child C status, we are going to advise them endoscopy only at the time of the bleed, which is wrong practice. Any insult in the cirrhotic, suppose cirrhotic patient develops fever, cirrhotic patient develops bleed, okay, it will further hampers their normal liver. Each and every insult will accumulate, okay, and it may lead to the less optimization or his waiting time is become crumpled. So even if it is a child B cirrhotic and there is a no signs of bleeding, you should advise endoscopy and you should advise a screening according to the screening protocol. In child A you can advise 3 to 5 years, there are different guidelines. In child B it is 1 to 3 years depending on the which type of the endoscopy has a previous report. In child C it is a 6 monthly, and if it is a bleed, any child status you have to go it 6 monthly. Another thing missing is the dietary advice. આપણને ઘણા લોકો એવું કહે કે ભાઈ શું ખાવાનું liver cirrhosis ના, એટલે many we are telling કે ઘી તેલ નહીં ખાવાનું. There is nothing related with the ghee tail in liver when it becomes cirrhosis. Okay, so you have to advise them a small frequent meal, adequate calories required. Some people says કે અમે તો સાહેબ રોજ fruit juice પીએ છે. Fruit juice is I cannot say it is detrimental, but it is not helpful because it is a low calorie diet. We require adequate calorie, we require adequate protein muscle mass, so high protein diet is mandatory. Another very important thing is you just advise the patient to the some amount of bedtime snack. Simple measure કે રાતે સૂતાના અડધી કલાક પહેલા થોડું ખાઈને સૂવાનું, અડધો વાટકો દૂધ પીને સૂવાનું. Okay, that will avoid a nocturnal hypoglycemia which is common in the cirrhotic patient and decreases the stress on the already injured liver. Third is the coffee. There is a one study, if you go for the 3 or 4 cup of black coffee per day, the odds ratio of progression of the fibrosis is relatively beneficial. So this is a simple measure. If patient doesn't develop a constipation because of the coffee, you can just ask them, you can take a 3 cups of the black coffee over a period of 24 hours and it may help. It may or may not help, but it is at least not detrimental. So you can take this rather than if you are a teetotaler, better to go for a coffee lover. Another thing is aggressive treatment of infection. Look, the normal rhinorrhea cold cough is different from the normal patient to the cirrhotic patient. When normal patients comes with the cold and cough, you just give some decongestant, okay, some anti-allergic and paracetamol. This is not the case with the cirrhotic. They are more prone to infection. So even normal cold, cough and fever, start antibiotic. So future, if it is a significant infection or patient's immune system is very fragile, you can avoid a breakthrough sepsis or hospitalization. Another thing what I have noticed that we have already discussed, that discard the mild transaminitis on OPD basis and avoid doing investigations on OPD basis. Suppose some patient SGPT is 40, 50, and if you say you don't require investigation, you are doing a crime. This type of patient is going to develop cirrhosis over a period of 10-15 years. So high SGPT 500, 800,000, because you are going to investigate, it is safer. Mostly it is a acute insult and recovered. But this type of SGPT or ALT around 50, 60, 80, 100, this may indicate underlying chronic liver disease. Suppose you don't want to investigate, just do one thing. Ask them to repeat that SGPT after 15 days or 1 month. If it is still elevated, then mostly you are dealing with some underlying chronic liver disease and you have to investigate them thoroughly. And there are only few etiologies which is reversible. Okay, one is hepatitis B, second is hepatitis C, autoimmune, Wilson's, NASH and alcohol. Okay, so once you find that the inflammation is going on, some injury is going on, you can emphasize the patient. Okay, don't take it lightly. Even if you are a little overweight, you focus on this. You reduce your weight, otherwise this report will indicate that after 10-15 years there is high possibility that you may develop cirrhosis. Use of the steroid, we afraid or we not used at all, that will be discussed by Dr. Akash Shukla. So I am not going to discuss in detail. So all we require is the sympathy to the patient. First of all, the hope. Even if it is a cirrhosis, few patients are reversible and avoid the transplantation. Even if it is a cirrhosis, by optimum treatment, you can give them enough time to arrange a donor as well as the finances. This hope should be inside you first. Then you can give hope to the others. Then you can ask the patient, okay, don't worry, this can be done. But first you should be convinced that this can be done. And knowledge. So, thank you. Now, we are inviting Dr. Gunjan Joshi. He is a practicing gastroenterologist in Rajkot, and we will see how will you evaluate jaundice on the OPD basis. And I will ask Dr. Harshil to invite a chairperson.
Dr. Nitin Shah, Dr. Prakash Foldu, Dr. Narendra Gadia, and Dr. Bhaumik Rathod. Please come on the stage, sir. Thank you. Thank you so much. Dr. Chintan Patel, please come on the stage, sir.
Respected doctors of Surat City, very good afternoon to all of you. At the outset, I am thankful to Dr. Saumin Shah for giving me this opportunity to interact with you. The topic which I am going to speak upon is pretty much routine. You must be knowing many things of my talk, and you must have encountered the more theoretical or serious or more important talks before this. So this will be more of basic, but I'll try to cover what we in our brain summarize as a gastroenterologist while we are dealing with jaundice patient in OPD. So as this is a OPD based approach to jaundice, I'll straightway jump upon the real life cases which I have come across in my practice. The first case is a 27-year-old male who had a classical prodrome followed by jaundice. On examination, had icterus and hepatomegaly with sky-high elevation of SGPT and SGOT. SGPT is better known nowadays as ALT, and SGOT is more better known as AST. But since we are more familiar with it, SGPT, SGOT, so I am using those terms. So SGPT was more than SGOT in this case, and both are in thousands with normal prothrombin time, mild hepatomegaly on sonography. Etiological workup revealed that he has hepatitis E seropositivity, and he recovered uneventfully. Young female with past history of recurrent jaundice on examination had pallor and splenomegaly, had indirect hyperbilirubinemia. The previous terminology for this is unconjugated, but we are again more familiar with that, so it is unconjugated hyperbilirubinemia. Total bilirubin was 5.4, out of which only 1.2 was direct. SGPT was normal. She has elevated retic count, 4%, peripheral smear suggestive of hemolysis, and HB electrophoresis confirmed that it was the hemolytic jaundice due to hemoglobinopathy for the recurrent episodes. Middle-aged male, chronic ethanolic, presented with jaundice and loss of appetite and nausea, direct hyperbilirubinemia with a bilirubin of 13.2 total, SGPT, SGOT mildly elevated, SGOT was more than 2 times SGPT, gamma GT with a normal cutoff of 64 was almost 10 times high, and with coagulopathy also, prothrombin time was deranged. He had diffuse fatty hepatomegaly and diagnosed to be having severe alcoholic hepatitis. Elderly male chronic smoker presented with progressive jaundice associated with itching and weight loss. He had palpable gallbladder, palpable lump in right upper quadrant along with non-tender hepatomegaly. On imaging found to be having pancreatic head mass with proximal biliary tree dilatation. He had significantly elevated direct hyperbilirubinemia and with elevated tumor marker CA19-9 was high, and he was preoperative biliary drainage was done for him for the high bilirubin in form of ERCP and biliary stenting. The last case is a 23-year-old young female, fever followed by abdominal pain, followed by jaundice and altered sensorium. On examination, had icterus, liver was not palpable, flapping tremor were present. Bilirubin was 7.8, SGOT 321, SGPT 226, significant coagulopathy. PT was 64 test value, and despite all measures, she could not be salvaged and died on the end of first week because of this episode. So what was the common in all this? That they all had jaundice. It is one of the commonest hepatobiliary symptom. Outcome depends on diagnosis and timely treatment. The first case was managed at home, hepatitis E, uneventful recovery. The last case passed away in ICU. So can be treated at home with oral drugs also, and patient can die in ICU despite all care also. So vast variety of outcome for a single common symptom. Timely referral plays pivotal role, and diagnosis is important for everything. Treatment, prognosis to prevent recurrence, and to answer questions to patient, media, and legal authorities nowadays. So while we are dealing with jaundice in our OPD patient, what question we should ask ourselves in our mind first? So what is the probable cause of this jaundice? What may be the approximate time the patient will take to recover from this episode, and with what treatment he will recover? And what would be the dietary advice and pharmacotherapeutic advice for this patient? Since I belong to Rajkot people are very frank and vocal, so they directly ask, who will treat? તમારાથી મળશે સાહેબ કે અમદાવાદ કે બોમ્બે જવું પડશે? They upfront ask, and if they say કે જો જવાનું હોય તો પહેલા મોકલજો, બગાડીને નહીં. So nowadays we face this question, who will treat? તમારાથી મળશે કે નહીં? So again the same thing, that we are supposed to ask ourselves this subconsciously when we are dealing with patient. Likely cause, anything alarming at this point, treatment, prognosis, need of referral, or am I referring well? Sometimes you are unable to reach up to the diagnosis. That's why you need to refer. Sometimes you cannot prognosticate, or patient doesn't recover as per your prognostication. Then you need to recover. Sometimes it is the deterioration of the patient, and sometimes it is the need of patient's wishes or relatives' wishes. So you need to refer. So to answer all this and to develop a significant diagnostic algorithm on OPD basis, we need to know little bit about jaundice. You must be knowing many of this theory. Yellowish discoloration of tissue, it can be sclera, skin, mucous membrane, or combination of this is what we call as jaundice. It is usually resulting from deposition of bilirubin. Deposition will take place when there is either imbalance between increased bilirubin production or reduced bilirubin clearance. And in many cases, there can be combination of both, increased production associated with reduced clearance also. And this type of combination will have faster development or deep jaundice. So if we do LFT, we do sonography, everything is normal and patient is just telling that I am having yellow skin, what could be the cause? That is the condition known as carotenoderma, which is seen with some of the quinacrine group of drug derivatives, phenols, and certain carotene containing vegetables. We come across one case of carotenoderma once every 2 years, usually in summer, કે જે રાજકોટ ઘણા બધાનું મોસાળ છે એટલે મામાના ઘરે આવ્યા હોય પછી too much of orange, peaches, jardalu they eat, and because of this peaches and oranges they can develop carotenoderma. So it is very uncommon, but it's not extremely rare, so you cannot come across. But the most important clue is yellowishness is confined to palms, soles, and forehead in carotenoderma, unlike the generalized yellowishness in jaundice. So cola colored urine is what the patients usually tell. Bilirubinuria is a significant finding when there is a cola colored urine in comparison to normal urine. So single slide about bilirubin metabolism, because I feel this is the most important slide. If we understand this, then it definitely helps us in our diagnostic approach. So we all know that senescent RBCs are prone for the intravascular hemolysis, and there are certain pathologies which can predispose to extravascular hemolysis as well. As a breakdown product of RBC, unconjugated bilirubin is developed, which cannot enter the hepatocyte, so it gets bind with the albumin, and through this combination, they gets transported into the hepatocyte. In hepatocyte, they are again transmitted with various ligandins. They are the Z proteins, and the conjugation takes place to glucuronide. So unconjugated bilirubin or indirect bilirubin gets converted into conjugated or direct bilirubin within the hepatocyte, and then it gets excreted through the intrahepatic biliary radicals into the biliary system, from where it goes to the extrahepatic biliary system, and through ampulla of Vater it reaches the small intestine. Conjugated bilirubin in the presence of intestinal bacterial proteases will get degraded into urobilinogen. In terminal ileum, 10% of the urobilinogen will get enterohepatic circulation, and it will get reabsorbed into the portal vein. Rest of the 90% will get converted into urobilin, then stercobilin, and then gets excreted into the stool. That is what is causing yellow color stool. So the pink portion is the blood portion, the top of the slide. Any disturbance at that level, that is pre-hepatocytic level, that is hemolytic jaundice. Any disturbance taking place into the hepatocyte itself, so it may be difficulty in conjugating the bilirubin basically. Any hepatocyte inflammation, injury, necrosis, then it is a hepatocellular jaundice. And anything which is affecting the biliary system as well as the small intestine, so ampullary region, extrahepatic biliary tree, then it is a obstructive jaundice. So this is how we can differentiate the three main types of jaundice, because the three main types have totally different diagnostic approach, totally different therapies, totally different outcome and prognostication. So from blood to liver, it is a prehepatic or hemolytic jaundice. From within the liver itself, it is a hepatic or hepatocellular jaundice. And between the hepatic duct to intestine, then it is a post-hepatic. That was the old terminology, post-hepatic. Now it is known as obstructive jaundice. There is one variant, that is cholestatic jaundice. It can be seen with hepatocellular jaundice also and obstructive jaundice also. In hepatocellular jaundice, the cholestasis, that means stasis of chole means bile. So stasis of bile within the liver, that is intrahepatic biliary radical. Then it is intrahepatic cholestasis, which is again usually a medical type of jaundice, drug-induced, viral-induced, autoimmune injury to the biliary tree. And the extrahepatic jaundice is from the common hepatic duct right up to the ampulla of Vater. Then it is a extrahepatic cholestasis, which is usually seen with obstructive jaundice. Coming to the first type, that is hemolytic jaundice. Usually we see only one thing,
disturbed bilirubin in the entire LFT. See, jaundice is one thing in which we take history, we examine the patient, but we may not be able to produce some provisional diagnosis on mind until and unless we get the liver function test done. So this is one disease in which the lab test actually opens our mind and narrows the differential diagnosis. So if we get the liver function test done, all parameters are normal, but only bilirubin is disturbed, then we are mostly dealing with the prehepatic jaundice or hemolytic jaundice. So normal bilirubin value is 0.1 to 1.2 milligram per deciliter in majority of labs, of which conjugated should be less than 0.3, and unconjugated can vary from 0.1 to almost total bilirubin, that is 1. So now how to term what is unconjugated hyperbilirubinemia and when to call conjugated hyperbilirubinemia. If the indirect bilirubin or unconjugated bilirubin is more than 85% of total bilirubin, then it is known as indirect hyperbilirubinemia. For conjugated, it is only the 50% cutoff is required. So that means the more than 50% is conjugated of the total one, then it is a direct or conjugated hyperbilirubinemia. Just to illustrate that, the serum bilirubin is 10. If the direct is only 1, that means 90% is indirect. Then this is an unconjugated hyperbilirubinemia. If the bilirubin is 10 but direct is 5.4, that means more than 50%, then this is a direct hyperbilirubinemia. For isolated bilirubin disturbance, that is hemolytic causes of jaundice, the responsible cause can be either it is indirect bilirubin is more, which can be seen with increased production of RBCs, hemolysis, ineffective erythropoiesis we come across very commonly. We give folic acid, we give injectable B12, and the HB improves, so as the indirect bilirubin. So ineffective erythropoiesis, massive blood transfusion, resorption of large post-traumatic hematoma, post-operative hematoma. These are the increased production, so pigment overload, what we can say is. Decreased hepatocellular uptake is usually seen with the certain drugs. Rifampicin is one of the common and most popular, and there is a isolated indirect bilirubinemia seen in almost 5 to 7% of the world population, that is Gilbert syndrome. So if you have ruled out all other hemolytic diseases, with HB electrophoresis, retic, G6PD, LDH, then you can stamp that this is a Gilbert syndrome. And they also have a previous readings, many values of indirect bilirubin. And the prognosis is extremely benign. They may develop slight elevation in bilirubin whenever they fast, prolonged journey, some illness. Okay. And then the third variety is decreased conjugation. There are some congenital and hereditary disorder like Crigler-Najjar syndrome, usually seen in pediatric population, type 1 and type 2, and physiologic jaundice of newborn. If we get LFT done and only conjugated hyperbilirubinemia, lest entire LFT is normal. For example, total bilirubin is 4, direct is 3, and everything else is normal, then we are dealing with these two rare syndrome. One is Dubin-Johnson syndrome and one is Rotor syndrome. They do not have any diagnostic test. Liver biopsy may get differentiated between them, but it does not require usually because they are benign and there is no treatment available. So if we investigate a patient who is having indirect hyperbilirubinemia with normal LFT, that means we are thinking in lines of in the line of hemolytic jaundice, then it is more of hematological workup. Reports એવા છે કે જાણે hematologist જે regular કરાવતા હોય એ ટાઈપનું આખું લિસ્ટ. Serum bilirubin total direct to label that this is indirect only, more than 85% of total. Liver enzyme to rule out because jaundice can have more than one etiology at a time. That is a multifactorial jaundice. So patient may have indirect hyperbilirubinemia and elevated liver enzyme due to some other pathology. So complete LFT is must. Reticulocyte count, LDH, haptoglobin, USG to look for hematoma, CBC, peripheral smear, G6PD level, hemoglobin electrophoresis, folic acid and B12 level to look for ineffective erythropoiesis. In selected cases, patients may require direct or indirect Coombs test and even to rule out PNH, paroxysmal nocturnal hemoglobinuria. Rarely we may require to do flow cytometry and bone marrow examination also to stem the cause of indirect hyperbilirubinemia. Now by far the commonest type of jaundice in the entire world is hepatocellular jaundice, and we also come across maximum of this type of cases only. So again the medicine textbook picture diagram, we need to examine a lot when we are coming across a jaundice patient. First to rule out, first to get some clue about the etiology like tattoos or multiple intravenous drug abuse or any other marks of chronic liver disease or chronic alcohol intake like scleral icterus, pallor, muscle wasting, needle tracks marks, evidence of skin excoriation, ecchymosis and patechi because of coagulopathy or severe thrombocytopenia, muscle tenderness and weakness, lymphadenopathy, then evidence of any other systemic cause which can have jaundice as a co-presentation like evidence of CCF or pneumonitis. Apart from that, there are specific markers also that we all know: Palmer erythema, flapping tremor, hysterexis, and decompensation of chronic liver disease can have jaundice as a first manifestation. So, ascites, hepatic encephalopathy, fetor hepaticus, of course, in some of the coma patients. And apart from that, subtle behavioral alterations and flapping tremor, of course. So there is a very long list of hepatocellular jaundice, and sometimes it is really challenging to establish the etiology of this in comparison to hematology, because in the hemolytic jaundice you have narrow DD and fixed investigation, while here is a more varied etiology. The commonest being hepatotropic virus inflammation, that is hepatitis A, B, C, D, E virus. Then there are several systemic virus which can have jaundice as a initial presentation, like Epstein-Barr virus, cytomegalovirus, herpes simplex virus. Then alcohol, drug toxicity, which can be either dose dependent like paracetamol, or it can be idiosyncratic, non-dose dependent like isoniazid. Environmental toxin, which can give rise to Budd-Chiari syndrome, hepatic vein thrombosis, pyrrolizidine alkaloids specifically. Then metabolic disease like Wilson disease, hereditary hemochromatosis, and there is a spectrum of autoimmune liver disease. Autoimmune hepatitis is one of the commonest of that. Then ischemic hepatitis, congestive hepatopathy because of the CCF or chronic valvular disease of heart, hepatic vein and IVC obstruction. Now investigation for this is little bit varied and challenging. Liver function test, viral serology whenever you are suspecting, autoimmune liver panel which includes anti-nuclear antibody, anti-smooth muscle antibody, then PNK level, anti-mitochondrial antibody, and there are several rare LC1 and there are rare SLA antigens. Serum ceruloplasmin and 24-hour urinary copper along with the slit lamp examination for KF ring. These three tests are basically for Wilson disease. Serum ferritin and transferrin saturation for hereditary hemochromatosis. Whenever you are getting USG abdomen done, always try to prefer Doppler USG, because we need to rule out several vascular causes which can be overlooked or missed by a routine sonography. So hepatic vein thrombosis, portal vein thrombosis, splenic vein thrombosis, IVC thrombosis. So try to have a Doppler USG. And if the diagnostic dilemma still persists despite the exhaustive workup, then sometimes liver biopsy is required to get the final etiological answer. So as I told, our approach to a patient with jaundice usually start with the liver function test. So whenever we are mentioning liver function test or LFT, at least we should insist that it should cover all this. And if they are not covering this in the lab, then try to mention each and everything separately, rather than to get patient convinced that something is missing, you need to give report a sample again. So bilirubin, AST, ALT, which are the marker of necroinflammation or hepatic markers. Alkaline phosphatase, gamma glutamyl transpeptidase GGT, which are the cholestatic markers. Serum proteins, total, albumin level, globulin level, AG ratio, they are the synthetic marker along with the prothrombin time. So bilirubin is showing the clearance or excretory ability of the liver. If there is necroinflammation, then SGPT, SGOT will be disturbed. If there is some intra or extrahepatic biliary cholestasis or obstruction, then alk-phos GGT will be disturbed. If there is an acute liver injury or chronic liver injury up to severity, then PT will be deranged. Usually in acute injury, serum albumin will not be low unless patient has some other issue like nephropathy or anything. But in chronic liver disease, the AG ratio will be reversed. So this is how we can have a bird eye view about what is wrong in the LFT and which way to choose, hemolytic, obstructive or hepatocellular. So coming to the last variety, that is obstructive jaundice. As I showed, the green part in this picture, anywhere there is some obstruction due to trauma, tumor, mass, stricture, ligation, injury, then patient may have a obstructive jaundice, which is usually characterized by itching cholestasis, and clay color stool. So causes of obstructive jaundice, benign commonest causes lower stone in the anywhere in the biliary tree, commonest being in the common bile duct. Then chronic pancreatitis associated biliary stricture. We have come across quite a few number of HIV cholangiopathy also. Then PSC, and among the neoplastic causes, malignancy involving the CBD, pancreatic head, gallbladder, ampulla, or any lymphoma causing the compression of the bile duct. So these are the common causes of obstructive jaundice. Now, if you see the investigation for obstructive jaundice is totally different from hemolytic and hepatocellular. This is more of radiology. So you need to correlate very well with your radiology. In hemolytic, you need to correlate more with your pathologist who is doing the hematology work. And for the hepatocellular jaundice, you need to coordinate with the serologist who is doing the primary serology test. So 3 different paths, 2 lab path, 1 radiologic path. So sonography of abdomen, I'll show pictures of almost all of them one by one. Then CT scan of abdomen, MRCP, magnetic resonance cholangiopancreaticography, ERCP, no more in rule, no more in use for diagnostic purpose since last 3 decades with the advent of other modalities. Previously, PTC was also used, percutaneous transhepatic cholangiography, but it is also no longer used with the arrival of endoscopic ultrasound. And rarely, if the dilemma still persists inside the operation theater also, then intraoperative cholangiogram. Biliary scintigraphy in selected cases to rule out acute cholecystitis. Intraductal sonography, choledocoscopy, and PET scan. So it is exhaustive list of radiological investigation. And this is what we are seeing is a lower CBD stone with a multiple sludge and calculi in the gallbladder. This is a typical sonography image, and the classical hallmark is posterior acoustic shadowing. Shadowing from the stone is there, and that is the radiological hallmark with the help of which radiologists will say that this is stone only. And these are the dilated intrahepatic biliary radicals. Along with that, portal vein radical is seen in the CT scan. And this is a classical Klatskin tumor or hilar cholangiocarcinoma that is causing obstruction at the level of hilum and significant dilatation of intrahepatic biliary radicals in both lobes of liver. This is the normal ERCP image. Intrahepatic biliary radical, just like a branch of a tree, is seen. Gallbladder is also opacified, CBD, pancreatic duct, and the thick one S-shaped is actually the side wing duodenoscope through which the contrast was injected. And side wing duodenoscopy, sometime to diagnose jaundice, even CT is showing subtle dilatation of CBD. You go with the scope and you see the periampullary mass. You take the biopsy and you put the stent to confirm that this is neuroendocrine or adenocarcinoma. So side wing endoscopy can also give us diagnostic clue. And ERCP, previously used for diagnostic purpose, has more of therapeutic role, removing the stone, dilating the stricture, putting the stents. And endoscopic ultrasound is showing the chronic pancreatitis with pancreatic duct stone. And this chronic pancreatitis has a fibrotic reaction which causes the lower CBD obstruction and obstructive jaundice. So sometimes we rely heavily upon this because they are easy to done. We just need to advise them on piece of paper. But these are the most misguiding or misleading tests. So tumor markers, we should closely correlate clinically and not just got carried away by the values. Alpha fetoprotein, CA19-9 and CEA. Alpha fetoprotein usually seen in primary hepatocellular carcinoma, CA19-9 in pancreatic tumors, CEA in colonic as well as biliary tree neoplasms, but they can be elevated in severe cholangitis also, even due to benign stone. So it is elevated, that doesn't mean always that it is a malignancy. So never prognosticate a patient based on this. Now coming to the last part, how will we approach? So again, simple question from the available reports, whether LFT is showing abnormal parameter only bilirubin or other than. So isolated hyperbilirubinemia or other things are also abnormal. If only hyperbilirubinemia, conjugated or unconjugated. Okay, then pattern of liver injury. SGPT, SGOT sky high, 500, 1000, 1500. Then you are dealing with viral infection, drug, ischemia, toxin. These are the 4 commonest likely possibility. If there are sky or first presentation of autoimmune hepatitis or fulminant Wilson. Okay, if there is a predominant elevation like alkaline phosphatase upper normal range is 100, your value is 600, 800, 1200, then it is more of a cholestatic jaundice. So you are dealing with some form of cholestasis, usually obstructive jaundice or intrahepatic cholestasis, along with the gamma GT elevation. Alkaline phosphatase is less liver specific than gamma GT. So if cost is not an issue, gamma GT is costing 500 to 600 individually as a test, but in combo panel, it may be even cheaper. So gamma GT should be done with AlkPhos. Even in normal pregnancy, alkaline phosphatase can be elevated. Even a growing child, alkaline phosphatase can be elevated. It can be elevated in several lymphoreticular malignancy also, several bone metastasis, and sometimes it is of intestinal origin also. So AlkPhos solely should not be used in interpretation when you are thinking in terms of the obstructive jaundice or cholestasis. Fourth question is there synthetic dysfunction? That is very important because the prognosis depends on the synthetic dysfunction. That means how the liver parenchyma is behaving with the disease or pathology. So PTINR and albumin globulin ratio. So acute injury, PTINR will be disturbed, albumin will be preserved. Chronic injury, both will be disturbed or one of them can be disturbed. Is there any dilatation of biliary tree on imaging? So you need to investigate for obstructive or not, and are there any combination of etiology? For example, patient is having hemolytic jaundice, and because of the hemolysis, patient has developed hemolytic gallstone, which has migrated now into CBD and causing the mixed variety of hemolytic plus obstructive jaundice. So is there any combination? That's why full LFT is important. If only bilirubin is disturbed, then hemolytic is okay. But LFT disturbed along with bilirubin, then think of dual pathology. So as I told, if in unconjugated, consider hemolytic. If conjugated, then hepatocellular obstructive. So serological workup or imaging will clarify that. Okay, predominant SGPT, SGOT elevation, presence of prodrome, absence of abdominal pain, presence of risk factor, possibly hepatocellular jaundice. Predominant alkaline phosphatase, gamma GT elevation, less of prodrome, presence of abdominal pain, itching, clay color stool, past history of any biliary tree manipulation, surgery, intervention, think more about obstructive. Fever should not be used to differentiate between hepatocellular and obstructive because low-grade fever will be seen in hepatocellular, viral hepatitis, high-grade fever, liver abscess, low-grade fever, pancreatic head carcinoma, obstructive jaundice, and high-grade fever in obstructive jaundice, cholangitis. So any type of fever can be seen in any of the pathology. So fever should not be a differentiating criteria. When all four enzymes are elevated, SGPT, SGOT, AlkPhos, GGT, then it is cholestatic hepatitis. So likely possible causes could be recent passage of CBD stone, drug-induced liver injury, and certain autoimmune overlap pathologies can also present like this. And when we are in dilemma, we can give 3 doses of injectable vitamin K and repeat the PT. If the deranged PT gets normalized, then it is obstructive jaundice. If it is not getting normalized, then probably you are dealing with hepatocellular jaundice. So for hepatocellular jaundice, acute or chronic, as I said, prognostication, because prognostication basis, you will decide when to refer, when to explain the guarded prognosis, when to explain the safe prognosis. Okay, so serum protein, look for chronic liver disease marker on imaging, nodularity, altered ecotexture, dilated portal veins, splenomegaly, collaterals, ascites. These are the radiological USG markers of possibly chronic liver disease. Is there any identifiable risk factor, drug, virus, liver, intravenous drug abuse, massive blood transfusion? What is the prognosis? Be it acute liver disease or chronic, PT is very important for prognosis. So what are the bad markers? જેને અમે સૌરાષ્ટ્રમાં કહીએ કે કયું પેશન્ટ ગલકું થશે. So these are the markers. SGOT more than SGPT, bilirubin rising, PT rising, SGPT, SGOT come down, but still AST is more than ALT, and appearance of new onset findings of decompensation. Ascites develop theory, altered behavior, oliguria, edema fit, new onset of decompensation symptom or GI bleed, then probably these are not the good patient to wait for further deterioration because they will not give you more time from here onwards. So now for obstructive jaundice, we need to identify the site, intrahepatic or extrahepatic, benign pathology or malignant. So radiologist will have a big role. Sometimes even FNA from the suspected lesion to confirm. Whether it is operable or inoperable, treatment is therapeutic, definitive or palliative. and basket of imaging studies and some guidance or at times misguidance from tumor markers to take help of. Okay. So last 2 slides, common myths which I have observed in jaundice. All jaundice are infectious hepatitis requiring antibiotics. Basically, if you are admitting viral hepatitis, they do not require antibiotic until there is acute liver failure and sepsis, or it's a chronic liver disease with SBP or some decompensation or septicemia. All itching in jaundice is due to obstruction of biliary tree. It is not so. Intrahepatic cholestasis is equally common, which is seen with viral and drug infection, rarely in alcoholic liver disease also. All jaundice cases require equal dietary restriction, very untrue. And prothrombin time is a hematological test. It doesn't carry any hepatic significance. This is also a myth, because even pathologists called me, ke sahib LFT ma PT thodu aave. Okay, so even they may not be aware that PT is LFT, part of LFT. So we need to mention specifically. And if you ask me which 3 investigation we should do, which are the cheaper and giving us maximum information on OPD basis for jaundice workup, one is CBC, but mention peripheral smear. If possible, talk to pathologists. Peripheral smear will rule out many hemoglobinopathies proper. They will have a look at thrombocytopenia also, sepsis is developing or not. Liver function test with PT-INR, of course, and sonography with area of interest being hepatobiliary tree. So we need to have an obstructive and Doppler study basically to rule out that. Thank you. Thank you.
Any question?
So suppose patient comes to you with bilirubin of 10, 6 indirect, 4 direct. Which type of jaundice is this? 6 indirect, 4 direct. Which type of jaundice is this? It is a hepatocellular, it's a prehepatic, or it's a obstructive jaundice. Total bilirubin 10, indirect 6, direct 4. How many are in favor of indirect, means prehepatic jaundice, indirect hyperbilirubinemia? How many are in favor of hepatocellular jaundice? How many are in favor of obstructive jaundice? So, no, but from this test, what is your interpretation? 10 total, 6 indirect and 4 direct. How many are in favor of prehepatic jaundice, unconjugated hyperbilirubinemia? हमना तो हाथ ऊंचा दिया पाछा અત્યારે જ બદલાઈ નાખે. So that is one of the slide sir has shown. If you want to stamp indirect hyperbilirubinemia, indirect bilirubin should be more than 80%. So this is a hepatocellular jaundice. એટલે હવે બધાને ચા પીવડાવો. Okay. Any other question in routine? Another અમારે સાહેબ છે ને તમે LFT કોણ તો HbSAg આપે, GGT અને પ્રોથ્રોમ્બિન ટાઈમ ના આપે. લીવર ફંક્શન. અને એનાથી વધારે સરપ્રાઇઝિંગ તમે સિરિયલ LFT કરાવો ને દર વખતે HbSAg આપે. ઓકે, સો ડિસ્પાઇટ ઓફ કોલિંગ કે સર ધીસ ઇઝ નોટ અ પાર્ટ ઓફ વાય યુ આર ચાર્જિંગ, છતાં બી કે ના સાહેબ અમારા તો પ્રોટોકોલમાં છે જ એટલે થઈ જ જાય એમ. I have observed. And GGT, usually in North India, GGT is a part of liver function test. In North India, when I was in Delhi, if you advise complete LFT, okay, GGT is automatically included. INR, prothrombin time is automatically included. Barabar. But in, I don't know about Ahmedabad, but in Gujarat, South Gujarat, when you advise complete LFT, GGT is lacking, prothrombin time is lacking, and they are giving a HbSAg. So complete LFT means it includes ideally GGT as well as prothrombin time. So I will ask Dr. Mehul Desai to felicitate Dr. Gunjan Joshi sir. So now our next talk will be of, I thanks all the chairperson. On the fatty liver. Now usually what happens when you see many fatty livers in sonography, okay, there are so many fatty livers in sonography. Once you see there is a fatty liver, usually you feel light બંધ કરવી છે, AC ઓછું કરવું, okay, so when you see the fatty liver, one, it is so common that we ignore it. Second, it is so asymptomatic that we ignore it. The unfortunately with the liver thing is that unless and until it becomes cirrhotic, it doesn't give you much symptoms. Okay, mild transaminitis, no symptoms, or mild fatigue is the only symptoms, unless and until you reach up to the stage of cirrhosis. So that's why what happens initially when suppose we will complete this CME, you will learn about the fatty liver, you will feel that we have to investigate the fatty liver on the OPD basis, you start investigating. After a month you see out of 200 fatty liver you have investigated all and you can find only 2 NASH. Okay, and from the next month onwards say okay, now there is no need to investigate fatty liver. This what happens because of the we are investigating and we can't find a specific what we call the population, but this 2% is important. Okay, if you keep keenness to find this NASH of this 2%, you can emphasize about the diet, exercise, though we don't have much treatment. You can investigate about the metabolic syndrome, so future quality of life will be better. So the prime concern of this talk, up to what level we should investigate fatty liver, and suppose we want to screen, should we investigate grade 1 fatty liver or it is not required, or should we investigate grade 3 fatty liver? So Dr. Pathik is a hepatologist in the Apollo Hospital, Ahmedabad, and he has his own clinic in the evening time, and he's going to inaugurate it on 25th June. So wish him all luck. So Dr. Pathik now is going to talk about fatty liver.
PPT. So thank you, Saumen Bhai, for inviting me to talk on fatty liver. So the first question that you have raised, why? I think today's discussion during Amit Bhai's talk was very clear. Everybody answered when everybody was asking how to treat it. So that automatically answers the first part of my talk, that is why do we need to actually evaluate this kind of patients. The question that we often see, and I have come across a lot of patients where they have been told previously by the doctors કે આ તો બધાને હોય, કંઈ કરવાની જરૂર નહીં, તમે લોકો જેને કરાવો ને એને તો આવે જ ફેટી લીવર. એટલે we all have faced this and we actually see that it is seen very commonly. So do we jump in for all these patients, or do we need to actually sit back and relax in these patients? So at the end of the talk, you would realize that 90% of the patients, you don't need to refer it to anybody. You yourself can manage these patients. Only 10% you would require further evaluation. And that is the purpose of my talk. So first question that I'll be answering is why. So why fatty liver needs to be evaluated? So let us understand how common our fatty liver is. So all the data that I am presenting is in Indian data. So this is all published in India. We have not taken anything from the West. All Indian and South Asian data. So if you look at the prevalence of fatty liver disease is nearly 30%. So 1 in 3 person has got fatty liver. So that is very common. But when we talk about obesity, so if somebody is obese, overweight, the proportion of fatty liver increases to 70%. So more than 2/3 of these patients are suffering from fatty liver disease. And somebody raised the question that they treat a lot of diabetics and there is overestimation of fatty liver disease. I think it is not overestimation, it is actually estimation. Tell me very honestly, all diabetologists, everybody of you treat diabetics, you get urine albumin, you get retinopathy tested, you get renal Doppler also done. But how many of you actually get a routine ultrasound abdomen done? How many of you actually advise a routine abdomen ultrasound for the patients who comes to you with diabetes? One. Overweight. But See, diabetic itself is a risk factor of a fatty liver disease, and 50% of diabetics do have fatty liver. So if you ask for a fundus examination, you ask for renal Doppler, now they have at least USG KUB, 5 or 6 USG KUB, but there is no mention of liver. The radiologist has to just look up and they'll see the liver. So please request you to get the liver also seen when you are sending to your radiology colleagues, because 50% of these diabetologists would have fatty liver. And if you are not obese, it does not mean you are not going to have fatty liver. So 1/5 of all the fatty livers are seen in lean patients. And again, this is not Western data, this is Indian data. And there is dyslipidemia is more commonly seen in these patients, and when we follow up these patients, they tend to develop diabetes. So if you see a lean patient who is having fatty liver on ultrasound, you need to follow up this patient, and they are likely to develop diabetes. Now I don't need to go into the detail of risk factors of fatty liver. It is already known about the risk factors, but one thing which I need to stress is hypothyroidism. So in our own data we proved, and there is a lot of data now showing that hypothyroidism is associated with fatty liver disease, and we need to actually evaluate these patients as well for fatty liver. Now why? So as I said, this just tells me that it is very common. All these diseases are associated with fatty liver disease, but why are we actually concerned so much about fatty liver? Why are all liver doctors obsessed about fatty liver? Every year there are 5 or 7 meetings just to discuss fatty liver disease. Is this 60% of the fatty liver can reverse just with lifestyle intervention. So if it is diagnosed early, this would reverse with lifestyle intervention. So if we pick it up early, before they develop complications, and we advise lifestyle intervention, we can prevent any further progression. But 25% of liver disease progress to further fibrosis in the next upcoming 3 years. And that once the NASH develops, spontaneous regression is unlikely. So our job is to pick up before they develop NASH. And once they develop progress to cirrhosis, there is no reversal. So our target is to pick up this fatty liver disease before they develop NASH. And again, one need to keep in mind that cirrhosis leads to liver cancer or hepatocellular carcinoma. Now NAFLD is becoming the most common cause of liver cancer nowadays worldwide. It is likely to overtake hepatitis B and C related cancers, and 30 to 50% of NAFLD cancers do not occur in cirrhotic. So I see a lot of patients who come to my clinic who have gas, acidity, dyspepsia, get an ultrasound done, and then they find a 9 centimeter mass in their liver, and which is now invading into the portal vein, and it is already BCLCC or D stage, where there is hardly anything curative to offer to them. So because this, when we ask them, how long did you have fatty liver? સાહેબ એ તો 15 વર્ષથી છે, પણ કઈ દવા જ નથી તો કરવાનું શું? એટલે અમે લોકો કરીએ છીએ, and then they don't have a regular follow up, and then they come with HCC. So HCC is something which we need to be aware of. So this is again an Indian consortium, Asian data, 1/5 of patients who come across with fatty liver. So imagine 30% of India's population having fatty liver, and 1/5 of this population having some or the other complications, and both hepatic as well as extrahepatic complications are common. And as I said, hepatocellular carcinoma or liver cancer is very common. Now just certain data points which will just, are so startling. I was even shocked to read this data. So presence of metabolic syndrome with type 2 diabetes increases the risk of liver cancer by 5-fold. NAFLD, as I said, can develop cancer in with or without cirrhosis. The type 2 diabetes increases the risk of HCC 2-fold and risk of death by 1.5-fold. If you are obese, the risk of HCC is double, but if your BMI is more than 35, the risk of HCC is 4 times as compared to a normal population. So somebody is saying that, bariatric surgery should be aggressive. Yes, if there is a BMI of more than 35, they are not walking, they are not exercising, they are on dyslipidemic agents, they are more likely to develop complications and liver cancer, and they are going to die. So we should be discussing bariatric procedure or weight loss procedures to these people. And once, as I said, the NAFLD related cancers, once they are identified, they are large, hypervascular, and there is, most of the times they do not get diagnosed in a early stage, they get diagnosed in a very late stage. So NAFLD is not just NAFLD and fatty liver, it can progress to complicated disease, and most common cause of death in the patients of fatty liver is not liver, it is heart disease. So it is a marker of systemic disease, systemic inflammatory disease, and these patients are likely to die of atherosclerotic cardiovascular disease, and that is what we need to be aware of. So if somebody has fatty liver disease, we need to be aggressively treating and preventing and identifying cardiovascular disease. So I think I conclude that Why we need to investigate fatty liver? Because the outcome is very bad and the complications are reversible in early stage if we are able to pick it up in early stage. Now, what extent? So there was a lot of discussion about fibroscan, point shear wave elastography and FIB4. So I'll give you a plan today on how do you proceed about it. But as soon as you see somebody with fatty liver disease, just do not jump onto the investigations. Let's go systematically. First of all, we know that metabolic syndrome is there. So start ruling out metabolic syndrome. Identify the risk factors. Take if alcohol, because alcohol is a confounding factor. Patient would not tell you alcohol and the presentation is exactly similar. We get a complete LFT with GGT done as already discussed, and we rule out other etiologies of fatty liver. So a person having fatty liver does not mean he cannot suffer from hepatitis B and hepatitis C. So we should still rule out all those diseases in anybody who comes to you for any liver disease. So ultrasound is the basic investigation. All patients should undergo an ultrasound, and ultrasound only tells you presence or absence of fat. So there is a tendency people get panicked by reading grade 1, grade 2, grade 3 fatty liver. They are actually grade and not stage. So it just tells you how much amount of fat is in the liver. It does not indicate the damage in the liver. So it is not the stage of the disease, it is the amount of fat in the disease. So ultrasound would only tell you whether there is fatty liver or not. And when ultrasound picks up the fat content in the liver is more than 30%. And to define fatty liver, we require just 5%. So we can understand how late an ultrasound picks up a fatty liver. So nowadays, there is a lot of promotion of using other techniques to detect fat, and fibroscan is one of the most wonderful machine that is available. So if there is a fibroscan machine, so there is something called as a cap value which comes in the fibroscan. So if the value is more than 280, it is indicative of presence of significant amount of fat into the liver. Now because we are so obsessed with numbers, a person who comes to you with 280 and 290 cap and becomes 300, 320, we need to tell them that is not going in the right direction. Even if the ultrasound still keeps on showing ultrasound grade 2 or grade 1 fatty liver, it may not change. It is not sensitive. Cap is very sensitive. The other technique nowadays is MRI. I don't think that it is commonly used, but we need to be aware that MRI can also be used to, MRI PDFF can also be used to assess fat. There are simple scoring systems available on the internet which tells you whether there is fat or not. So one of them is fatty liver index. So you just need BMI, waist circumference. I think you get it done for all your diabetic patients. GGT and lipid profile, that includes triglyceride. On the basis of that, this score will tell you where your patient is likely to have fatty liver or not. You don't need an ultrasound. This is a screening test which you can do it in your clinic. So all this just told you whether there is fat or not, but it does not change anything. As I said, whether you are supposed to give pharmacotherapy or you are supposed to actively intervene depends upon the presence of fibrosis. So there is a lot of data which says that if there is no fibrosis, it is just the lifestyle interventions which affect. But if there is fibrosis, then the complications are very high and you need to treat them pharmacologically. So how much, if we see 25% are likely to have fatty liver disease, just 1 or 2% are likely to have NASH in your clinic. So if your 100 patients you are seeing in your clinic, 25 would have fatty liver, but of those 25, just 1% would be having an advanced disease. This is what you are all, you should be interested in picking up. And how do we pick up this disease? So because, as I said, we don't treat simple fatty liver. So somebody said, that's a common answer, okay, full LFT. But SGPT and SGOT is the most misleading test in the patients of fatty liver. So more than 50% of the time you have damage or steatohepatitis, it may be still normal. And most commonly it is in diabetics. In diabetics, your SGPT, SGOT remains 20, 25, but there may be significant progression of fibrosis. So normal LFT does not rule out that there is no inflammation or no fibrosis in this patient. So LFT is misleading, yet we should be getting it done. Liver biopsy cannot be possible in most of these patients, and that is why we come on to the non-invasive test. So this is the list of non-invasive tests which are available to screen the fatty liver disease. I would not ask you to read the complete slide, but I would advise you to just remember these three: FIB4, NAFLD fibrosis score, and APRI index. And it is freely available on the internet. You have to just write FIB4 score, and it would come to your screen, and it just you need to enter the basic CBC and LFT values. It does not require any advanced test. If you are getting a complete CBC and an LFT, you can calculate these scores easily. So this is the most and the first foremost test that you do in a fatty liver disease. So patient comes to you in your clinic who says that mane fatty liver che, how am I supposed to proceed? Get a CBC LFT, calculate a FIB4 score. What is the interpretation of FIB4 score will come at a later, but this is the serological test, easily available, and we do not advise elastography and all those tests to all the patients. So I divide the patients, the serological test and elastography test. Now there is some confusion. Now all the radiologists have learned the technique. They don't understand the difference between a fibroscan and elastography. So it's like they are using a toothpaste, but where they are calling all toothpaste as Colgate. So the test that all radiologists are doing on an ultrasound machine is called as a point shear wave elastography, and it is not a fibroscan. The report that they give is fibroscan, and which is to be opposed. It is not a fibroscan value. Fibroscan is actually a brand name which is by a machine which is produced by Ecoscience from Paris. So the fibroscan is actually a transient elastography, which is a type of shear elastography, while the ultrasound or radiologist, the machine that they do is a point shear wave elastography, is a kind of RF test. Though both are considered to be equivalent, but they are not the same. There is discrepancy in the absolute cutoffs of this, so you should not be using the same cutoffs of fibroscan when our other tests are being done. I have specifically put in this image, so I don't know, most of now know how a fibroscan works. It's like an ultrasound machine with a probe. There is a vibration is created, and the speed or the velocity of that vibration wave is detected. The faster the wave travels, stiffer the liver is, more is the value. So that terminology is called as LSM, or liver stiffness measurement. And besides liver stiffness measurement, there is one value that is CAP, which indicates the fat. Now there is a Chinese counterpart of fibroscan machine, which is known as a FibroTouch machine, which is also available nowadays very commonly into the market. But instead of CAP, that they use, the value that they used is UAP. The photo that I have taken in this is specifically for FibroTouch, and it is UAP. So again, it is not a fibroscan report, it is a FibroTouch report, and the value is UAP. Now UAP is not equivalent to CAP and should be differentiated. So please ask your friends to be very specific that if they require elastography or a fibroscan. So this is what the radiologists do, point shear wave elastography. The advantage that this gives is you can direct where you want to check the test, but it is still yet to be accepted as equivalent to fibroscan, and we are hoping that in next few years this would be considered equivalent, but not as of now. So for fibrosis, we can do serological test and this elastography test. Now elastography, in our own data in Western India, we have published data that fibroscan is very good. This is the original fibroscan, and if we want to use the serological test in our data, APRI score or aspartate transaminase to platelet ratio, so AST and platelet values came out to be much superior as compared to FIB4 score, but this was limited to our population in our study. MR elastography, Amit Mandot has left, but their center does MR elastography for fibrosis, and they have done more than 5,000 MR elastography. It gives you a wonderful, and the Western cutoff is 3.6. In their study, the cutoff is coming out to be 2.9. So first step, diagnose fat. Second step is to assess the fibrosis. So we diagnose that there is fatty liver. We assess that there is presence or absence of fibrosis. We ruled out risk factors, we ruled out other etiology, and then we come to the management. So management is not just prescribing couple of medicine, it is a multi-pronged approach: obesity treatment, risk reduction, and then treating the NASH. So as it was discussed that weight loss is the most important. So more than 10% weight loss I advise to all my patients, but if we see all the data, persistent more than 10% weight loss is not sustained. Only if somebody loses 10 kgs of weight, they are going to regain in some time. So only less than 10% of these people actually maintain the weight. The next question that you will come across in your clinic would be su khao ne su na khao. So this is again Indian data where they looked at more than 2000 products, and as we all can understand that high consumption of refined rice, animal fat, red meat, sugars, fried foods were linked to development of fatty liver disease. But this is just limited to Indian study. When we carried out a systemic review and meta-analysis, we found out that food item does not matter. What we found out is the calories that matter. So some people would come to your clinic and say, "અમે તો કઈ તળેલું ખાતા જ નથી, તો પણ અમારું વજન વધે છે." So it is the absolute number of calories that you take and the calories that you burn. So you need to teach your patients that જે ખાઓ છો એ બાળો. ભલે ને તમે હેલ્ધી જ ખાતા હો, પણ જો એ બાળી ના શકતા હો, તો this all extra calories are going to be converted to fat and being stored in your liver and would promote fatty liver disease. So there is enough evidence to say that. So શું ખાવું જોઈએ? So what is scientifically recommended is just one diet which has definitely be proven useful is Mediterranean diet, and I don't think any good Jews would be interested in following a Mediterranean diet. The other thing is coffee. Now there is a lot of strong evidence that black coffee, 3 cups of black coffee a day helps improve fatty liver and a lot of liver disease. So again I would stress the term black coffee. So a lot of people would come and say, "અમે તો રોજ coffee પીએ છે," but that is full of sugar and milk. That doesn't work. It has to be 3 cups, 200 mils of black coffee which works. So Mediterranean diet, black coffee, and calorie reduction should be your dietary advice. Coming to intermittent fasting. So nowadays people come to my clinic and ask me, "Sahib, intermittent fasting karaye ke na karaye?" So I used to oppose that in the initial part because there was a lot of fad and બધા જાઈને કે સાહેબ intermittent fasting કરીએ છે. But there is strong and very strong evidence that intermittent fasting is significantly beneficial to fatty liver disease, and that helps weight loss as well as NAFLD reduction. There is a lot of papers which say that intermittent fasting is useful, that is time restricted feeding is beneficial. So if some patient is under the care of a nutritionist, is willing to get a treatment done, please ask them to go ahead. Coming to physical exercise part, physical exercise, I would say that nobody does it. When most of our fatty livers would say કે સાહેબ મને ઘૂંટણ દુખે છે ને વરસાદની સિઝન છે ને ગરમી છે ને ઠંડી છે, and they never exercise. But exercise remains an important part of the treatment. What kind of exercise? There are 2 types of exercise. One is called endurance exercise, which is swimming, cycling, running, and others are resistance exercise, which is weightlifting. So which exercise to recommend? Does anybody have an idea? Cycling. No gymming? Swimming. Gymming, yeah, so mixing. So I also believe the same thing, that you should be doing 3 days a week resistant and 3 days a week. So this has been my advice for till a month back. But there is a lot of recent trials which shows that endurance exercise, that is cycling and swimming, are beneficial over gymming for fatty liver disease. So this should be your lifestyle modification: low calorie diet, moderate intensity exercise equal to sustained weight loss. Coming to treatment, most of the treatment had been discussed, but I generally personally divide fatty liver treatment into diabetic treatment and non-diabetic treatment. So the main trial which has started everything is vitamin E and pioglitazone. So small word on vitamin E. Now a company has come up with a new molecule of vitamin E, which is T3 molecule, and there is a lot of data which says that it may be beneficial as compared to the T4 molecule, which had been routinely available. It is believed to be more antioxidative, anti-inflammatory, and it is more potent. Coming to, I'll just discuss certain diabetic agent because all of you treat diabetes. So pioglitazone, everybody recommends pioglitazone, but the dose which is recommended, if you can see in this study, is 45 milligrams. How many of you actually use 45 mg pioglitazone? Should not be used. Weight gain, heart failure? Side effects. So everybody says pioglitazone vapro, and the dose recommended is 45, which we are not giving. So that was the major reluctance of everybody of us of you are using pioglitazones. But good news is that there is a lot of now data coming up that says that 15 mg, 30 mg and 45 mg all work equally. So if your patient is taking is non-obese and taking 15 milligrams of pioglitazone, it is useful, and you should consider this as the number one treatment for your diabetic patients with NAFLD, the pioglitazone. Saroglitazar I would not discuss, it has already been discussed. But there is a similar molecule to saroglitazar, which is a lanifibranor, which might be competing with saroglitazar and would be available. It is undergoing phase 3 trials. If it is successful, it would come out into the market again. So saroglitazar with pioglitazone. Coming to GLP-1 RAs. So this is the main study which changed our perspective, and we concentrated more on weight loss. So lean study which were used, liraglutide was used and showed significant benefit in the fatty liver, and that led to interest in GLP-RA, and then came the trial of semaglutide. So semaglutide trial for fatty liver disease was published in NEGM, and they showed a lot of benefit in the steatosis, but not significant in the fibrosis. But I think it was a short study. If we follow these patients for 5-7 years, there would be improvement in fibrosis as well. But this study was carried out with injectable semaglutide. So now we have an oral semaglutide available in the market, and can it work or not? So there is now again data to say that oral semaglutide also is beneficial in these patients of fatty liver disease. So obese, non-diabetic NASH patient can also be considered for semaglutide. But again, this is not a recommendation, this is an understanding, which I would end with my study in the later part. Coming to which GLP-RA to be preferred for NAFLD. So if you are prescribing GLP-RA, I think there is a lot of preference for dulaglutide by the diabetologist. But if there is a fatty liver, I would advise that you may consider liraglutide or semaglutide in this patient, which has definite role, more promising role than dulaglutide. Somebody raised SGLT2 inhibitors. So SGLT2 inhibitors are also, there is a study between where they have shown that empagliflozin, canagliflozin, and recent data where dapagliflozin also is shown to be beneficial in fatty liver disease. Then again you will ask which to choose, SGLT2 inhibitors or GLP-RAs. So if the patient is affording, there is data to say that GLP-RAs are preferred over SGLT2 inhibitors. And pioglitazone and SGLT2 inhibitors are equally efficacious for patients with NAFLD and type 2 diabetes. Again, there is data to say that. Obeticholic acid, I think the entire discussion of obeticholic acid is pharma driven. The initial approval and the worldwide approval is only for primary biliary cholangitis. It is not approved for fatty liver disease, and it is not equivalent or similar to ursodeoxycholic acid. They cannot be replaced. It is a toxic agent, obeticholic acid, and should not be used routinely. And this is a warning given on a black box warning given by the original innovator, where they say that there is a severe risk of liver injury. So please be very selective when you are using obeticholic acid. Ursodeoxycholic acid, be very honest. How many of you write ursodeoxycholic acid for fatty liver? Nobody. So I honestly write, but there is Western data is against the use. All guidelines say that it doesn't work, but the data from China, India, and Middle East is quite supportive for UDCA. My own trial I carried out probably now 8 years back, where the efficacy of UDCA was equivalent to vitamin E. So if you consider 30-40% of response of vitamin E as good response, then UDCA also normalizes the enzymes, but it does not normalizes the fibrosis. That you need to keep in mind. So before I end my talk, this is the American recommendation of what you should be treating with fatty liver disease is vitamin E and pioglitazone. So vitamin E, lean persons without type 2 diabetes, mellitus or cirrhosis. So, and there is now data to say that it is safe in cirrhosis as well. But generally it is recommended in non-diabetic patient, and if there is diabetic patient, you consider for pioglitazone. But GLP-RA, SGLT inhibitors is not, the role is not fully defined and requires further investigation, but there is very promising data. So this is AGA and just published, I think last year, September. Italian guidelines again recently published, and they also say that if there is type 2 diabetes and there is a lean patient, the option that you are having is pioglitazone. So pioglitazone is the official recommendation. Coming to the guidelines, Indian guidelines, I think it has already been discussed, but there are only 3 molecules written into that: vitamin E, pioglitazone and saroglitazar. So all 3 molecules are officially promoted by Indian guidelines as for the treatment of NAFLD in these patients. So how do you approach a fatty liver in your clinic? Please, anybody with diabetes, get an ultrasound and look at the liver, not just the kidneys, because this is far more common than CKD. So if they have fatty liver disease, you label them as fatty liver. Now get a CBC and LFT done and calculate FIB4. If FIB4 is less than 1, you don't need to refer the patient. You just advise lifestyle modifications. If FIB4 is more than 1, that is when you advise for further tests, which may be elastography. This elastography, I prefer a fibroscan, but there would be data later which may say that shear wave elastography is equivalent. And if fibroscan is less than 8, again you can manage with lifestyle modification, but if the fibroscan is elevated above 8, that is where you need to refer these patients to liver doctor. So there is actually an article in World Journal of Diabetes, NAFLD in diabetes, when to refer to a hepatologist. So anybody with altered enzymes, you should consider referral. But if there are no altered enzymes in these patients, calculate a FIB4 score. FIB4 score is abnormal. Look at the fibroscan, and if it is abnormal, only then refer the patient to a hepatologist. So I conclude my talk that non-invasive tests are simple clinic-based tests and not always need of high-end radiological instruments. You can use it on your own. Vitamin E is the current recommendation. Anti-diabetic are winning the race against the liver-specific agents for the treatment of fatty liver disease, and you all are trained and accustomed to use these agents. Use it wisely and look for fatty liver and select the agents which may benefit fatty liver as well, but individualized care is the treatment of the R. Do not stop atorvastatin. This is my advice in these patients. So there is a tendency, SGPT 50, 55, you stop atorvastatin, do not stop. It may not be useful. And I end my talk, so I am inaugurating my clinic next week, next Sunday, and I would be more than happy if somebody can join in. Thank you. At what? See, acute hepatitis, I stop it. Otherwise, SGPT 50, 100, 120, 250, if it is because of fatty liver and not because of atorvastatin, I do not stop it. So that is acute hepatitis. So 250, 150, 200 above it goes. And again, if it is a reversible, say for example, a patient is of IHD, develops dengue hepatitis and dengue hepatopathy, and then it temporarily goes up to 300, 400, I would not stop it. This is hepatopathy. Acute hepatitis like viral hepatitis E, when enzymes goes up to 1000, I would consider temporary withholding, otherwise not. So vitamin E official recommended dose is 400 milligrams twice daily, and duration, I think it was a lot of discussed in the morning. What duration? The safety is for 5 years. You can give it for 5 years. We have now started using it in cirrhotic patients also, so it is quite safe. The risk is actually overestimated of hemorrhage. From the benefit perspective, I don't know when I would be able to stop it, but I actually tell my patients practically, this is my, that I give you 6 months. I would stop the medicine 6 months, you would lose your weight. So my medicines are not going to burn the fat. My medicines are going to give you time till you burn your fat. So you burn your fat in 6 months, and so that my medicines are going to protect your liver in that time. But yes, you can give it for 5 years, vitamin E, and but if it has not worked in 1 year, I don't think it is going to work in 5 years as well. Yeah, so again, Amit touched upon this topic that so it's like a hypertensive approach where we can combine different agents with different actions. But as of now, no recommendation is made because they have not studied together. But a lot of people do combine vitamin E with saroglitazar. and they themselves are using, and you automatically are using, for example, a lot of your diabetes would be on dapagliflozin, and you add on as an add-on anti-diabetic agent, you add lipaglyn or saroglitazar. So automatically it's a combination therapy. And then you, because now the patient says fatty liver mate to kai kapo, then you add vitamin E or UDCA in that case. So we already are treating it, but there is no data to support or antagonize it. So official recommendation, if the fibroscan is in normal range, is once a year. If it is more than 8, it should be done between 3 to 6 months. Simple USG in a cirrhotic patient 6 months, non-cirrhotic patients yearly, annually. So again, I actually hit the slide. L-carnitine is considered to be a nutraceutical. Silymarin, L-carnitine, they are all nutraceutical agents. So they are believed to be beneficial. So the purpose is vitamin E. But if, there are a lot of, now there is a mixing and matching. A lot of companies are coming with 5 different molecules which are liver protective and coming. So L-carnitine is an add-on nutraceutical. It is not officially recommended for treating these patients of fatty liver disease. Yes, so I presented that Evion is T4, Evitol, which this Abbott company promotes. I think they are the only one promoting this, is T3 molecule, and it is shown to, believed to be, I would not use the term shown to be, believed to be better, but it is only a long-term data would come in. Theoretically, it is definitely better. Real world scenario, I think you and we can get together and do an RCT T4, T3 and see the results. But yes, we do not have a real world significant data. It is all theoretical. Taurine, again, it's all these are nutraceuticals. They studied around 25-30 nutraceuticals, and they say you can consider it, but there is no, the weight loss is the treatment. The paper concluded saying that weight loss is the treatment, but if you want to add nutraceuticals, it does have some beneficial role. This is what they concluded. Now, what nutraceutical between the comparison, we don't know. So we cannot control those things. So I actually wrote a letter to editor in one of the hepatology journals that, there was a lot of discussion about bridge course. When Ayush practitioners were undergoing a bridge course and they can practice allopathy. I think it should be reverse bridge course. We all should be taught some form of Ayurveda. We have absolutely zero understanding of Ayurveda and we have no idea. Now, anything Ayurveda we say nahi levanu. No, we also deep inside know कि कदाच खराब ना भी होए, खराब होए भी खरू आपने के खबर नहीं. So this is something which we all don't know. Giloy definitely know because I have come across and we have all published a lot of data about its side effects. But there are other agents like Leaf52. I would say I have seen all physicians, gastroenterologists prescribing Leaf52. So I'll give you I'll joke about it. Like, there was a patient with metastatic liver disease and there was nothing that I could do for the jaundice in that patient. So I referred to an oncologist, ke bhai, you have something to offer, you offer, and the oncologist writes Leaf52 and sends the patient back to me. So Leaf52 is the best example of the Ayurvedic molecule. The studies that they are carried out are not sufficient to accept this molecule. We should be forcing Himalaya to do a genuine trial and prove that it works, then we all be happy to use it. But I do not say it is bad. I have no data to say it is bad. How can I say it is bad? Yeah, so the studies they have done where they have used vitamin E in non-diabetics. So the data that we have accumulated is in non-diabetic population. It's not something which is contraindicated, but if the data is in non-diabetic, for diabetic we already have pioglitazone. So all worldwide guidelines recommend pioglitazone for diabetic NAFLD patient. So we can at least start 15 milligrams in this. So there are no drugs which are contraindicated in fatty liver. So see, there are certain agents like methotrexate, tamoxifen would cause fatty liver, but if they are needed as a disease modifying agents for other illnesses, you are supposed to give it with monitoring. So the fear of methotrexate in all recent literature says that we have been scared unnecessarily and we have been doing a lot of liver biopsies unnecessarily for methotrexate. And if we have to just monitor. So if you have fatty liver, it just tells you that there is fat in the liver. It does not mean that the liver is damaged. In a cirrhotic patients, yes, I would avoid NSAIDs and everything, but for a fatty liver, no, you live like a normal life except for lifestyle modifications. Thank you for patient hearing.
Dr. Sandeep Patel, please come on the stage for good wishes to Pathik sir.
Hello. Now, next is Dr. Tanmay Vyas. He is hepatologist and he did hepatology course from ILBS, and right now he is doing practice in the Ahmedabad and predominantly working in the Sterling Hospital. Now topic is the asymptomatic transaminitis. That what I have emphasis during my previous talk. Asymptomatic 50 international unit per ml, 60 international unit per ml. Should we investigate? How much investigate? And why should investigate?
For this session, chairperson is Dr. Tarun Chawda, Dr. Paras Roy, Dr. Rajendra Patel, Dr. Parthiv Patel. Please come on the stage and set this session.
Hello. Yeah. So, good afternoon, everyone. I bring greetings from Ahmedabad, my center, to all of you, and thank you, Dr. Saumin Bhai and its team for allowing me to interact with you. So, in my talk is for regarding evaluation of asymptomatic transaminitis on OPD basis. So what we are going to talk in 20 minutes is, we are going to talk only about asymptomatic patients, so not touching any jaundice, ascites or pain in right upper quadrant or like that. Transaminitis, actually it is a wrong term. It is a transaminases plus itis means inflammation, so it is not a transaminases inflammation. It is because of inflammation, because of injury, these transaminases in the liver are I think light is very much, so it won't work. Pointer won't work. So basically in this left side, what the cartoon is shown is ALT, aspartate transaminase and alanine transaminases. They are the intracellular enzymes. So once there is damage, insult or injury to the hepatocytes, it will increase, it will causes death, inflammation of the cells, cell wall damage, and these enzymes will be liberated outside the hepatocytes into the blood in a more than conventional amount. So these enzymes get elevated. So we are going to talk only about the AST-ALT elevation and not alkaline phosphatase, GGT or bilirubin elevation. And these are OPD patients. No sick, no indoor patients we are going to talk about. So hepatocellular injury, that is hepatitis. This is silent, so this is subclinical hepatitis. So modify it medically, we are going to talk about the subclinical hepatitis. We are going to see few cases and understand. So why we want to evaluate such subclinical hepatitis? The reason is we need to identify the liver injury or insult at an early stage because they are the early markers. We need to identify the cause why this injury has happened. We can also identify the chronicity of insult, whether it's acute or chronic, severity of insult. We can prognosticate, we can decide the treatments to salvage the liver, and we can decide when to refer the patient, where are the warning signs or which are the signs of concern in such asymptomatic subclinical hepatitis group. So moving to the first case, the case 1, she is a 45-year-old female, had complaint of elevated SGPT, that is ALT. I am going to use ALT for SGPT and AST for SGOT, so won't discuss again. So ALT was 112, she was asymptomatic. She had past history of hypertension, diabetic, dyslipidemia, and now we are in a modern era. She had history of alcohol use as well, 4 to 6 packs per week. She was on drug, statins, angiotensin receptor blocker, and metformin. On examination, she was obese, 29 BMI, pulse was 80, blood pressure 130/78, on medications, abdomen, liver, and spleen were not palpable. And these were her previous SGPT level. So if we can see properly, in 2020 it was 46, 2022 it is 86, and now in 2023 it is 112. So it is a gradual slow increase in SGPT level. If we see down, SGOT, that is AST, is normal. Rest of the LFT markers were normal. So if we encounter such patients, what could be the possible differential diagnosis, especially in such patient? First will be fatty liver, because metabolic syndrome we have seen she had. It could be viral hepatitis, bystander, or primary causing SGPT elevation. It could be drug-induced liver injury. She was on statin, or ARBs also can cause, or some other medications like complementary alternative medicine, she might be using for weight loss, we don't know. She was alcoholic, so she had habit of taking alcohol, so could be alcoholic liver disease or autoimmune hepatitis, we need to understand, or could be other diseases. This SGPT and other enzymes, SGOT, can come from muscles, from RBCs, from thyroid as well. So if SGOT is elevated, then we need to consider such as well. So how to narrow down such large differential diagnosis when we encounter subclinical hepatitis? So we can divide into the two parts, predominantly ALT elevation and predominantly AST elevation. So why this difference in the AST-ALT elevation, though they both are hepatocellular enzymes, intrahepatic, and they are marker of hepatocellular injury. So I'm showing this cartoon. So this side, this is a portal vein. This is a central vein area. So zone 1, zone 2 in hepatocytes, basics. So if we see, in zone 1, ALT is more concentrated than AST. And in zone 3, AST is more concentrated than ALT. Apart from that, there are many other differentiation, direction of blood flow, redox potential, but I am not going into detail about that. Another part is the location of enzymes. AST is in mitochondria and very less in cytosol, and ALT is mainly in cytosol. So those who can attack mitochondria, cause mitochondrial injury, will have more AST elevation. Who cause cell wall injury, maybe ALT elevation is more. So depending on that, this can give us hint about what could be the differential diagnosis. If ALT is predominantly elevated, it could be typical hepatotropic viral hepatitis, A, E, B, C, or could be drug-induced liver injury, or could be fatty liver. There are other causes as well, but we are considering now only common causes. If AST is predominantly higher than ALT, then it could be alcoholic hepatitis, autoimmune hepatitis, cirrhosis of liver, or could be hemolysis, strenuous exercise, myopathies, etc. So again, this is for asymptomatic OPD basis common causes. I am not going into the detail of all the lengthy causes. So moving back to the case 1 again, she had PT elevation, ALT of 112. ALT is more than AST. Typical hypertrophic viral markers were done, which were negative. HbSAg, HCV, anti-HCV were negative. If we talk about the metabolic parameters, her weight was in 2020 62, gradually increased in 2022. They quote that after lockdown it has gone up, right? So 2023, 10 kg more than 2020. And it is reflected in the SGPT level as well. So BMI also gone up. So it is a case of fatty liver disease, non-alcoholic fatty liver disease or metabolic dysfunction associated fatty liver disease. And I want to highlight the learning point in that ALT is always higher than AST in fatty liver patients. They are associated with metabolic syndrome. Always look for obesity, diabetes, insulin resistance, hypertension, triglyceride more than 150, HDL less than 50-40 in male, female. Waist circumference is also very important because most of our Indians or Asians patients, they are not obese, BMI 23 to 25, they are overweight still. But waist circumference is high. જે આપણે કહીએ આપણે ફાંદ વધારે છે કે તોંદ જ્યાદા है. તો that is driving the visceral fat and that is causing the problem. And it is also seen in those who give indication by increased SGPT level, their SGPT level will correlate with their metabolic lifestyle diseases. If they put on weight, their SGPT will increase. If their bad lifestyle, junk food, more party, then there is SGPT will increase over a period of maybe 3 months, 6 months, 1 year. And remember the last point is also very important. If SGPT is going above 180, or 200 in a confirmed case of fatty liver, we need to find out the additional cause of additional liver injury. So for example, we are asking if statin is, they are using statin, and if it is going above 200 or there is additional drug induced pathology, we are suspecting the fatty liver are more, drug induced liver injury is more common in fatty liver patients. So those hepatotoxic drug when we are using in fatty liver, LFT should be monitored. If it is going above 200, we should suspect that there is additional component of injury apart from fat only. We move to the case 2, same kind of picture, 45-year female, asymptomatic, this time SGPT is 206. Same metabolic risk factor, same BMI. So it is going 306. In March 2022, it was normal. At that time also, weight was 76. In May 2023, it increased to 206, but weight is still 75. So weight has not gone up. Metabolic factors have not deteriorated, but still SGPT has increased, and that is above 180 to 200. So there is some additional factors which is causing the issue. So what is these factors? Viral markers negative. USG liver in March 22 showed fatty liver grade 1. Weight I have already discussed, and this SGPT has gone above. So if we miss this history, then we cannot catch the diagnosis. The history was she had right breast cancer, underwent modified radical mastectomy. After chemotherapy, she was on hormonal therapy. That was tamoxifen because ERPR receptor was positive. So we went ahead with the liver biopsy, and it confirmed that it was a case of drug-induced liver injury. Here, there are many types of drug-induced liver injury. Here, it was chemotherapy-associated steatohepatitis. So, on top of metabolic dysfunction-associated steatohepatitis, there was addition of chemotherapy-associated steatohepatitis. That is why it was increased. So, learning point in drug-induced liver injury causing subclinical hepatitis is drug history and timing of drug intake and the liver enzyme elevation should be correlated. So, there should be spatial correlation to document or to confirm that this drug might have caused the drug-induced liver injury. It is more common in fatty liver patient, more common in female. ALT is always more than AST. They are elevated, that is hepatocellular drug-induced liver injury. If alkaline phosphatase GGT is also simultaneously elevated, it is cholestatic drug-induced liver injury. Most of the DILI have mixed kind of pattern. And most common drug causing DILI are antitubercular treatment, co-triamoxazole, nitrofurantoin, NSAIDs, fluconazole, chemotherapeutic agent, anti-epileptics, and many. And also complementary alternative medicines, including Giloy. So we move to the case 3. 48-year-old male had he is a head of a big CA firm. he is asymptomatic. He used to underwent annual health checkups and worried about fluctuating SGPT, SGOT level. Why he was worried? Because his father had died of cirrhosis of liver. So these were her serial LFT. He has maintained, he was doing annual health checkup by himself and not much getting opinion of expert. So if we see in detail the first line, ALT, from 2013 to 2023, it kept on increasing till 2018, but after that it started decreasing. So his question to me was whether my liver is improving or deteriorating. Why this is funny, enzymes are getting elevated and then it is coming down. The answer is in ALT-AST correlation. So if we talk about initial part, ALT was higher than AST. But in the last part, this is hiding behind that image that now AST is higher than ALT. So we'll go into detail after that, but we take the detailed history. He denies of any medical disease. His sonography was showing fatty liver. It was reported once. Though he's denied of medical disease, he had fatty liver. Though he denied of medical disease, he had low HDL level. Not on any medications at all, no addiction, and BMI was 25. So not that obese as well, but fatty liver. Other enzymes, alkaline phosphatase, GGT, bilirubin, albumin, were all preserved. INR, synthetic functions were all preserved. But look at the platelet count. So it has, since 2018, it has started dropping down. 3 lakhs, 2 lakh 28,000 and 2 lakh 16,000. HB was almost same. So what has happened from between 2018 to 2023? So anybody can say what has happened from 2018 to 2023? Why the SGPT has gone down? Yes. So we all understand that this is he's developing cirrhosis, so enzymes are getting exhausted, SGPT more than SGOT, so SGOT now increasing, and SGPT is exhausting more. So viral markers, as a workup, we had to do it. Viral marker negative, HbA1c was 6. ANA was done, autoimmune marker, 1:40, mild positive. Asthma was 1:40, 1 plus only positive. Fibroscan was done, which was showing 15 kilopascal, and CAP, which is a fat quantification in a Fibroscan tool available, which is 300 decibel, equivalent to S2 steatosis. And liver biopsy was done, and which confirmed that it was NASH-related cirrhosis with 50% of steatosis. So if we apply in a particular this case, suppose we didn't have Fibroscan and we didn't do liver biopsy. So if we had applied at 2018 the FIB-4 and APRI score, so FIB-4 in 2018 was 0.41, which was normal. APRI in 2018 normal, 0.25. So sometimes we cannot confirm in a particular case that whether FIB-4 will rule out fibrosis or not. So FIB-4 and other parameters of non-invasive testing are for mass population, guideline, screening of those population. So sometimes we miss also when we are already having SGPT, SGOT elevation track for long duration, we confirm that there is some injury is going on and we have to take that. To pick up unknown patients who are heading towards injury, we need to do this FIB-4 and APRI score. So as the cutoff value is low, APRI and FIB-4 has good sensitivity, but specificity is very low. As the cutoff is high, specificity increases, but sensitivity decreases. That we know. Another is Fibroscan. We already covered. Same way in Fibroscan, in F2, positive predictive value is high. And to rule out F4, positive predictive value is very high. Negative predictive value is very high. If we talk about the non-invasive tests which are available in this asymptomatic subclinical hepatitis patient, this has a very important role, which is rule of 5. If it is Fibroscan is 10, there is chronic liver disease. If it is 15, there is advanced chronic liver disease. If there is more than 20, along with low platelet count of 1,50,000, it has can rule in clinically significant portal hypertension. The same way, Pathik has already covered that Fibroscan has also additional pathology, additional tool which quantify fat, which sonography detects only after 30% of steatosis. So in S1, which is 5 to 33% steatosis in liver, so cutoff values are like this, 248. In S2, 268, and S3, this is 280. There may be overlap. And he has already covered that it is in guideline for screening, as a screening tool for other community practitioner, that FIB4 and fibroscan can be used. I am not going into detail of that. So learning lessons in cirrhotic asymptomatic hepatitis patient is, it is a silent progressive disease, patient won't have any complaint. Change of enzymes pattern or relationship is very important. Platelet count fall is important. AST to ALT ratio, FIB4 APRI is important. But role of USG in picking up the fibrosis is limited. The way in picking up early steatosis it is limited. In picking up early cirrhosis also it is limited. If by chance, there are many cases, instances where patient sonography is showing fatty liver disease, patient underwent surgery for cholecystectomy and the liver is cirrhotic. Though the sonography is showing fatty liver, at the same time, the patient under naked eye examination, the liver was cirrhotic. If we do biopsy, it is cirrhotic. If we do fibroscan, it is cirrhosis. The sonography has limitation to pick up the early cirrhotic patients. Fatty liver grade 1 will develop to grade 2 and grade 3 and then to develop cirrhosis. It is not true. So sonography is showing fatty liver grade 1, then also the patient can directly go to cirrhosis because there could be exhaustion of fat as well. So normal ALT level also can progress to cirrhosis, or while having cirrhosis, they might have normal ALT level as well. This point has been already discussed. So we move to the case 4. Patient is having chronic kidney disease. He is on maintenance hemodialysis, referred for asymptomatic increase in SGPT, SGOT. So SGPT, ALT is higher, 286, AST is low, 120, bilirubin is 1.8, total direct 1.1. CBC is preserved, platelet count are preserved, and ALT is higher than AST. So again, our differential diagnosis from the left panel, which were there, fatty liver, drug-induced liver injury. So all antiviral markers, including A, E, B, C, were done, which were negative in this patient. We went into the 3 months back LFT. It was normal. There was no hepatotoxic drug. We checked it, confirmed it. 2D echo was also done because sometimes they have some congestive hepatopathy as well, which will mimic like this picture. So 2D echo was left ejection, ventricular ejection fraction was 55%, RVSP was 32, no pulmonary hypertension, no diastolic dysfunction. So this is a high risk group CKD having viral infection, communicable viral infection probability. So HCV RNA was advised and which was done and which was 4 log. So why anti-HCV antibody was negative? So this answer is here. Initially in acute hepatitis C infection, SGPT will increase, viral load will be higher, patient may or may not develop symptom, but anti-HCV antibody will take 3 months maybe to develop and to get detected. So that is the window period. So when we are high index of suspicion, still that is viral hepatitis, so we need to ask for this HCV RNA in hepatitis C, or atypical viral marker should be done. So it is a case of acute hepatitis C viral infection. And the last case I am going is 28-year-old male, newly married, recently traveled for honeymoon. After coming back, he had nausea, vomiting. 2 condensatron, 8 milligram TDS was initially considered that it could be food poisoning. He consulted a doctor who advised CBC, SGPT and urine routine micro. That is common advice in periphery also. So these reports are like this. So SGPT was 600. But by the time when patient had already taken ondansetron and patient was asymptomatic, the consultant advised to take ursodeoxycholic acid, leave 52 as discussed, sorbilin. These 3 were given. But when after 2 days, he came back in ER with a drowsy status. He was admitted in ICU and become unconscious next day. So if we compare the first OPD visit, SGPT was 600. Second, when he was in ICU, the LFT were like this. SGPT 1600, SGOT 1200, bilirubin 8, direct 6, INR was 4.5. So it is a case of hyperacute liver failure, fulminant hepatitis A. What I want to highlight in such OPD patients, whenever there is higher than 5 to 10 times upper limit normal elevation of SGPT or SGOT, that is acute rise in SGPT or SGOT, it is a rapid acute hepatitis, severe hepatitis. We need to get INR done. If it is more than 1.5, it is a fulminant hepatitis. We should admit him, look for the encephalopathy, and to prevent or early detect hepatic and acute liver failure. So most important, as discussed previously also, INR is important in such kind of rapid rise in acute cases. So if we want to summarize the overall 5 cases, the case 1 was fatty liver, ALT was higher than AST, ALT was usually is less than 180 in fatty liver related elevation and associated with metabolic syndrome. In case 2, it was drug-induced liver injury, same, ALT was higher than AST, ALT can be more than 200. Drug history in detail is very important to crack this cases. Liver biopsy may sometimes require to confirm the diagnosis. Case 3, it was cirrhosis. There was chronic insult going on from 2013 to 2023, which was neglected by patient in spite of his father died of cirrhosis. AST was more than ALT was the hint to early diagnose that cirrhosis. Non-invasive test has very much role in such kind of cases. In case 4, it was acute HCV. Again, ALT was higher than AST. Conventional viral marker were negative, but when you are very much sure that there is no other differential diagnosis, you have to, and high risk group was there, so we need to rule out certain non-hepatotropic virus as well as this HCV RNA. Case 5 was fulminant hepatitis, when there is rapid rise in SGPT, SGOT level of more than 5 to 10 times upper limit normal. There is a definite role of INR, we should not miss it, and even if it comes normal, we need to monitor it, ask patient to monitor it on next day or day after, depending on the SGPT repeated and INR. If SGPT is improving trend and INR is stable, we are not worried. If SGPT is decreasing or SGOT is decreasing but INR is increasing, we are more worried that they are ALF patients. So identify ALF early and refer in a proper center is very important. So after these 5 cases, only last bonus case is case 6. A father brings his 14-year girl child. She is asymptomatic at present, but there was altered LFT. And he was told that it was related to viral hepatitis. At that time, CBC were like this, SGPT 630, bile salt, bile pigment present. She was given IV fluid, antiemetic, proton pump inhibitor, and on medication orally the same kind of medicines were given. She recovered in 4 weeks, so that chapter was closed at that time. We couldn't find viral markers A and E, but it was assumed that it is common that hepatitis A and E infection in young children, waterborne infection, it is common. So second episode, no reason was found. There was some history that she took some pills advised by gynecologist for menstrual issues. She recovered in 2 weeks. This has episodes recovering. But now, when she came, right now she is asymptomatic. So look at the enzyme, serial enzymes pattern. At the 2 years back, 6 months back, and now when she is asymptomatic, ALT is 232, AST is 868. So AST higher than ALT. Cirrhotic, autoimmune hepatitis, alcoholic hepatitis. Alkaline phosphatase GGT little bit elevated, bilirubin this time is 3.3. HB is, if we see serial HB, 14 to 12, now it is 10. Total counts 3,500, now it is 2,800. Platelet count 267, 175, 77. So whether these enzymes elevation are because of cirrhosis, how many will say it is because of cirrhosis? Few, right. So why it is not that we will discuss, but what we did was sonography was showing just hepatomegaly and splenomegaly. Fibroscan showed LSM of 10 kilopascal. LDH was 400, retic count was 5, ANA was strongly positive, 1:80 titer it was positive, IgG was elevated, direct scum test was 3+. So liver biopsy was also done at that time. and she confirmed to be a case of autoimmune hepatitis with only F2 fibrosis. So in cirrhosis, usually SGPT and SGOT never goes above 200 or 300 if the enzymes are exhausted. But in certain cases, in hepatic fibrosis, non-cirrhotic fulminant hepatitis, it can go up. So again, in such kind of patients, so there is a limitation of FIB4 and APRI. It is very high in 6 months back also. It is very high at right now also because there is a confounder. Platelet are affected because of something else. SGPT, SGOT are falsely elevated because of disease itself. SGOT is higher than SGPT because of disease itself and not because of fibrosis. So when there is a confirmed case that this is a liver injury patient and requires attention, this marker has no role. But if it is in a community practice, it has very much role. So this is a case of autoimmune hepatitis with autoimmune hemolytic anemia. She was given steroid, and within 3 months, her all LFTs were normal, platelets, CBC, everything got normal. And on follow-up scan, there was no fibrosis. So early stage, early pickup, and it was done. Fortunate enough that 2 years back and 6 months back, she didn't have major life-threatening fulminant hepatic failure. So learning from this all are any AST ALT with more than 1.5 INR should prompt us to confirm that it is a severe acute insult or it is a persistent underlying chronic insult on top of acute insult is there, and that is why INR is going up. So INR has very important role even if patient is asymptomatically elevated AST-ALT. Rising AST-ALT and INR has suggests that it is insult is increasing or persistent. Fluctuating AST-ALT and INR, like in last case, case 6, it increased, came back to normal, again increased, patient was normal. So fluctuating is a very important characteristic of autoimmune. Also in certain other cases, higher AST to ALT ratio for more than 2 years or higher any AST or any ALT for more than 2 years, persistent insult should not be neglected even if patient is asymptomatic because we want to avoid chronicity, fibrosis. AST more than ALT, AST more than 200 should be considered alcoholic or autoimmune related acute hepatitis, could be fulminant, we need to check INR. Same way, ALT going more than 180 to 200, it could be viral or DILI, could be fulminant, INR should be checked. And changing pattern should prompt us to detect cirrhosis early. So my take home message, any patients comes to AST ALT in increase AST ALT in OPD, the step 1, look what already have been done. In past history of past acute illness, recent acute illness, long duration chronic illness, ask for alcohol and drug intake. Drug history is very important. Most of the time they do not try to recollect what drugs they have taken in past. We need to spend time to ask them in a different way to elicit the drug history. Examination is also important to rule out the chronicity and other part. And past serial lab records gives us so many information to come to the diagnosis before we order any further investigation. So this thing, step 1 already was done in patients, already we have when patient comes to us with asymptomatic AST-ALT elevation. The next step is order the further investigation judiciously based on AST-ALT pattern, the relative values, full LFT and PTINR, that includes GGT. We are asking in Ahmedabad also, Saumin bhai, we have few corporates in LFT, they don't do SGOT also, and SG and GGT also. So that is very common, it's not only common in Surat. So viral markers and metabolic syndrome markers should be done in a particularly appropriate cases. Autoimmune marker should be done, but remember the autoimmune marker could be falsely positive in 33% population. So if it is clinically suspected, then only proceed for treatment after confirmation. Non-invasive testing should be done based on the scenario. And invasive testing in liver biopsy sometime is required even if patient is asymptomatic to confirm the etiology and treat and salvage the liver. So with that, I thank you. And
anyone have a question? Please ask.
Yeah, obviously. So metabolic syndrome, the most important, it is the epigenetic disorder. So epi means environment, diet, lifestyle, what we discuss, that it has to be modified. But the genetic part is very important. Those who have maternal side and paternal side, both side strong metabolic risk factors, they develop cirrhosis early, they progress it fast, or fatty liver they develop early, they progress fast, and chances of lean NASH is also common. Those father and mother both are diabetic side, paternal, maternal, that is also common. Yeah, so in Asian population it is high. So overweight with additional risk factor, they are vulnerable for fatty liver or MAFLD. So he had risk factor of HDL low, sonography was already showing fatty liver, so he was a high risk.
And this is true for, sir, many liver etiologies. This is not about the NFLD. Suppose the person whose father is alcoholic cirrhosis and person used to drink alcohol. Now it is known fact that the whoever drinks alcohol, it doesn't mean it leads to the cirrhosis. But a patient with the alcohol consumption and his father has a history of cirrhosis, they are more likely to progress towards the cirrhosis. Okay. Same for hepatitis B. Suppose hepatitis B runs in the family and the parents are the carrier, there are more chances that these patients will remain carrier rather than become active hepatitis. But parents have a tendency of developing HBV cirrhosis or HCC. This fellow with the HBV positive has also have more tendency to develop cirrhosis and HCC. So this, apart from the NASH, we can see this in many other etiologies. Autoimmune, we can see it is a many time hereditary, but in other cases you can also see that. Nephropathy, possibility of that. So many rules are blindly from metabolic syndrome, you can blindly imply to that fatty liver. IHD, history of IHD, possibility of IHD is higher. History of hypertension, possibility of hypertension is high. The same is.
For felicitations, Dr. Sonal Chawda madam and Dr. Tarun.
Just sharing my experience, excellent lecture, Tanmay. 4 patients whom we could detect non-hepatobiliary cause while we were just evaluating SGPT, SGOT. One turned out to be celiac disease, one hyperthyroidism, one myositis, and one cardiac source. So cardiac. So we just need to keep our antennas up beyond the hepatobiliary system while evaluating SGPT, SGOT without any symptoms.
So there are many systemic diseases which can cause SGPT, SGOT elevation.
It is not a very severe elevation like 1000 or something like that. Okay, but it is in the range of 200, 300. Your other workup is negative, patient is anemic. And anemia is not necessarily a very severe anemia. It may be 9 gram, 10 gram, but you should enclose because there are only few etiologies. If you detect earlier, I have one sister in TriStar Hospital. Okay, he in 2015 when I was just came Surat before in 2014, and he referred for me for the anemia, and they referred for the endoscopy, colonoscopy. But when I see the profile, his constant liver profile is deranged. Okay. So I have advised autoimmune, everything without doing endoscopy because there is no obvious history of blood loss or excessive menses. And then I have advised IG anti-TTG and it turned out to be a positive. We did a D2 biopsy. It also suggests of severe form of the celiac disease. And that sister went for the gluten-free diet. And after 6 months, I'm just telling of 6 months, his hemoglobin from 6, it improves to 9 without any iron supplementation, and transaminitis is completely subsided. She had a history of single-time ascites also before 4 or 6 years. But these are the few. That's why I'm telling if it is a mild transaminitis, just look for hepatitis B, C, autoimmune, NASH, celiac, which is reversible in the early stage. Okay, suppose she was not diagnosed at that stage, and now 2023, she presented with the cirrhosis with full-blown ascites. At that time, gluten-free diet is still beneficial, but it is not up to the extent that right now she is living with the good quality of life. So celiac disease is but it is usually one of the pathologies. One of my friend,
is pathologist in Surat, and she had anemia, and she consulted almost 4 or 5 gastroenterologists across the Gujarat, and everybody has diagnosed her as a IBS, irritable bowel syndrome. Okay, because of the she is a little bit stressful, anxious, and in 2014 I just came here, and we are a very good family friend. So I just said, you just go for this because your hemoglobin is just 9, and it turned out to be a strong positive. Okay, so this reversible etiology should kept in mind. Thyroid. Okay, thyroid usually when you find a fatty liver or some other disease, you usually another symptoms are there, so usually you ask for it. Okay, but celiac disease is another, though it is a relatively unusual, it is more common in the North India. It is a relatively unusual, but you should always look for in CLD because it is one of the very, I personally feel the reversible etiology without medication. You have to just become a South Indian, okay, and I just advise sister that you have to marry some South Indian guy and you have to eat idli dosa every day. Okay, automatically you will be cured. So this is a relatively a good disease when without medication you can improve your quality of life.
Also Wilson disease can
Wilson's.
any metabolic liver disease also can present like this. Wilson disease can present as anything from asymptomatic hepatitis, subclinical hepatitis, fulminant hepatic failure, cirrhotic, ACLF, anything.
So
Dr. Sonal Chawda madam, Dr. Tarun Chawda sir, please come on the stage for felicitation to Dr. Tanmay Vyas sir. Please come on the stage. Our last session is a Dr. Akash Shukla presented to steroid in hepatology, underutilized or better utilization. For this session, chairperson is Dr. Harshit Chaudhary, Dr. Devang Desai, Dr. Jayesh Shah, Dr. Bijal Kapadia, and Dr. Bhavikan Chaudhary. Please come on the stage, sir, for this session.
yeah, you can sit there. It is just like a family. I told previously because we know each other. This is just like a family. Okay, so my one of the why we are I ask you to become a chairperson. To be very frank, so one of the very good reason, once you give us some, this you 5 people, at least you 5 people have to remain attentive for the lectures. No, you can, but there are few peoples, if they એને પાછળ બેસાડો ને તો ધીરે 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 ઊંઘ એના ઉપર અસર કરે. પણ અહીંયા બેસાડો એટલે they have to listen. Because at the end of the talk, I will ask, sir, તમારે કાંઈ પૂછવું હોય તો, તમારે કાંઈ પૂછવું હોય તો. So, this is the reason we make chairperson. Dr. Akash Shukla is a director of hepatology in Reliance Hospital, Mumbai. And he cannot come because of the fever. And I think he is going to take lecture on the steroids in the liver disease. This is another thing, if we can use judiciously in cirrhosis, okay, or early stage of the cirrhosis, in few etiology, we can prevent the transplant. Or we can give or optimize the patient, and we can give time to the patient to arrange the logistic, finances, donor for the transplant. Akash sir, am I audible?
Yeah, I can hear you, Somin, very nicely.
Okay. Thank you, sir. You can start now.
Thank you, Somin. At the outset, I must apologize for not being able to make it personally. And thank you for having me for this important meeting. So I'll start with autoimmune hepatitis. Very often people ask me, when a patient comes, can we give steroids for autoimmune hepatitis? If yes, can we just start based on the blood reports, or do we need to do a biopsy? When do we suspect that the patient is actually having autoimmune hepatitis? So if you look at the clinical spectrum of autoimmune hepatitis, it is very varied. It can come as acute liver failure. It can come as acute and chronic liver failure. It can come with cirrhosis. It can come with just elevation of SGOT, SGPT. And it can even come with just jaundice. So there is a huge variation in the presentation of autoimmune hepatitis. So how do you diagnose autoimmune hepatitis? It is based on the typical phenotype. That is, you have to exclude other chronic liver disorders. you should have evidence of autoantibodies, elevated gamma globulin, and typical or compatible histology. So these are the things which we should keep in mind. Elevated IgG levels, especially when there is no cirrhosis, is a very important feature of autoimmune hepatitis. Although, if the patient has cirrhosis, then IgG levels can be elevated even in the absence of autoimmune hepatitis. Now, when you look at the EASL guidelines, they talk of histological demonstration of hepatitis is a prerequisite. So unless you have a histology to prove that this is autoimmune hepatitis, you should not start these patients on steroids. And this is one of the commonest reasons that I see for misuse of steroids. I see patients who have come with jaundice, elevated enzymes, ANA is positive, so the patient is started on steroids. This is not adequate to label somebody as autoimmune hepatitis. So if you look at the diagnostic algorithm, if you have a liver disease of unknown origin, you do the autoantibody tests. If the autoantibodies are positive, you consider AIH, you will do liver biopsy. If the autoantibodies are negative, and you still think that this could be autoimmune hepatitis, you will still do rare tests for autoantibodies. And if they are positive, you will consider AIH and then do a liver biopsy. So it is important, if you look at the algorithm, that liver biopsy is mandatory. Even if we look at the pediatric population, even in pediatric population, we must have biopsy to diagnose autoimmune hepatitis. If you look at another algorithm which is there, suspected AIH, you will immediately do both antibodies and liver biopsy. And then, depending on what you find on liver biopsy and autoantibodies, you will make your diagnosis. I was very happy listening to the previous talk and the discussion on celiac disease. So here again, you can see that celiac disease comes into the picture. Why we are not giving importance to autoantibodies so much, especially for confirmation of diagnosis? That is because the prevalence of these autoantibodies, ANA, ASMA, is very common even in the healthy population. And especially in women, it is very high. So it is positive even in patients with NAFLD, it is present in healthy population, and therefore just presence of autoantibodies is not sufficient to start somebody on steroids. This is again another study on NAFLD. 21% patients with NAFLD have autoantibodies. So even in the absence of autoimmune hepatitis, these antibodies can be positive. So by themselves, they are not diagnostic. Biopsy is a must. In pediatric population with NAFLD, again you see almost 1/3 would have one or the other autoantibody positive. This is Indian data from the East. 27% of non-pregnant adult Indian women, healthy population, had positivity. Now coming to immunoglobulins, we discussed that elevation of IgG is very important diagnostic part of autoimmune hepatitis. But by itself, again, IgG elevation can be seen in any liver disease. If you look at the simplified scoring system, the diagnostic criteria that we use includes autoantibodies, IgG levels, liver biopsy, and absence of viral hepatitis. And if you have a score of 7 or above, then only you can call this patient as definitive autoimmune hepatitis and start the patient on steroids. Now to reiterate what I just discussed, these are 3 women whom I have seen in the last 3 months. All have elevated transaminases, 3 to 10 times upper limit of normal. All had elevated IgG, and all of them had positive autoantibodies in the last 3 months. The biopsy of the first lady was this. It turned out to be NASH. This was the biopsy of the second lady, which turned out to be drug-induced liver injury because of losartan. And this is the biopsy of the third lady, which turned out to be a primary hepatic lymphoma. Same presentation, fulfilling the criteria for autoimmune hepatitis, but biopsy showing completely different. And this is where, unless you do a good liver biopsy and you have a very good pathologist who can read it, you will make errors if you give empirical steroids to these patients. So in fact, I was having a dinner a few days ago, and I discussed this with everybody. All of you know these people. We have Dr. Sareen there. We have Professor Karela from Spain, Dr. Ajay Duseja, Dr. Sehgal, and all of them agreed that unless we do a biopsy, we will give unnecessary steroids to a lot of patients. The next place where we talk of steroids is in alcoholic hepatitis. Now, we know that of those who drink alcohol in heavy quantities, around 90% will develop fatty liver. Of these, 20 to 40% would develop alcoholic hepatitis. And of these, around 1/4 would develop severe alcoholic hepatitis, and 20% will have progressive disease to go on to develop cirrhosis, and around 3 to 10% of them would develop HCC. Let's go to a patient. 43-year-old male consumes 180 ml of whiskey per day for 5 years. He is asymptomatic. On routine health checkup, is found to have mildly elevated bilirubin 2.4, SGOT of 123, SGPT of 145, albumin is 3.9, platelets are normal, INR is normal. So this patient will qualify as mild alcoholic hepatitis. Ultrasound is just showing fatty liver. So this patient comes to you. So if I have a quick survey in the Somin, if you can help me do this. How many for option A? How many of you will prescribe Silymarin to this patient? Metadoxin, S-adenosylmethionine, UDCA, pentoxifylline, steroids, all of the above or none of the above. So let's start with option H. How many of you will not give any of these drugs? Someone, if you can just tell me how many are voting for what?
Most of the people is none of the above.
Very good. So I think this audience is a brilliant audience. So this patient actually does not require any therapy. This is a complex pathogenesis of alcoholic hepatitis. And each of these pathways is targeted by one of the drugs that we just mentioned. Many of these drugs are naturally occurring substances like Silymarin, curcumin, the LIV52, pentoxifylline, and S-adenosylmethionine. All these have been tried in different clinical trials. All of them have some role in improvement in liver function, but they do not save lives. None of these drugs improve mortality. So in patients with mild alcoholic hepatitis, abstinence and nutrition is sufficient. That is the standard of care, and nothing else needs to be done. We move on to the second case. 35-year-old male, alcohol for last 10 years, jaundice for last 15 days, ascites for last 10 days, slowness of response for last 2 days, no GI bleed, and no comorbidities. Last drink was 12 days ago. So this patient will, on all probability, has deep jaundice, ascites, so he fulfills the criteria of acute and chronic liver disease. We will have to prognosticate this patient based on the different prognostic scores, which could be the Medrey's discriminant fraction, which is the commonest that we use, the MELD score, the EBIC score, or the GHA score. So we use the Medrey score, which is 4.6 into PT test minus PT control plus bilirubin. And if it is more than equal to 32, we call it severe alcoholic hepatitis. So for severe alcoholic hepatitis, what is the treatment of choice? So the first thing that we look for is whether there is a contraindication to steroids or not. So what are the contraindications to steroids? Presence of severe renal dysfunction, presence of advanced hepatic encephalopathy, presence of active peptic ulcer disease, presence of GI bleed, and active infection. If none of these are present, then we would give corticosteroids. You assess the response at 1 week. If the patient doesn't respond, then you look at liver transplant. If there's a contraindication to steroid, then whether you can reverse the contraindication. If you can reverse, good, you can go ahead and give steroids. If you cannot, then you look at liver transplantation. If the liver transplant is not an option, then we look at the clinical trials for these patients. Why this recommendation has come? It was because of the STOPA trial, which looked at over 1,000 patients with severe alcoholic hepatitis, and the use of steroids was shown to be beneficial. Pentoxifylline did not show any benefit. But if you look at the 1-year survival, there was no difference with any of the therapies. So prednisolone will give you short-term survival benefit. The long-term survival benefit will be there only if the patient remains abstinent from alcohol. The 28-day mortality was different, but the 90-day mortality and 1-year mortality was the same. So in our patient, the DF was 109.2. So he was evaluated for eligibility of steroids. The urine routine showed 200 to 300 pus cells. The cultures were sent. Patient was started on norfloxacin. Ultrasound was normal. In 48 hours, urine showed 2 to 3 pus cells. The ascitic fluid was done, which showed no infection. The chest and abdominal CT was done. Always do it to rule out any focus of infection. An endoscopy showed no active ulcer, small varices, mild PHG. So this patient, we thought, would be an appropriate choice for giving corticosteroids. So the next question comes, is it necessary to do a liver biopsy prior to giving steroids to this patient? How many of you would do a biopsy in this patient? Samin, can you just tell me how many would do a biopsy?
Sir, I was little bit outside during presentation, but if it is a pure case of severe alcoholic hepatitis, I rather start giving steroid for 5 days and look for the scoring rather than doing a biopsy, because alcoholic hepatitis biopsy, unless and until you are unsure it is alcoholic hepatitis or not, then and then we go for biopsy. Otherwise, I don't go for biopsy.
So this is again one of the controversial areas, whether we should do a biopsy or not. So when we talk of use or abuse of steroids, in patients with alcoholic hepatitis, if the patient doesn't have alcoholic hepatitis and you give steroids, you will cause much more damage than benefit to this patient, especially if he is a cirrhotic. So if it is just a decompensation of alcoholic cirrhosis, then giving steroids will actually be associated with increased mortality. So why is liver biopsy recommended before we give steroids to patients with alcoholic hepatitis? Because 30% of patients whom you will label clinically as alcoholic hepatitis will have their diagnosis changed on biopsy. So 1/3, that means every third patient we will be wrong if we give them steroids just on the basis of clinical judgment. So whether they meet or do not meet the clinical criteria, the recommendations say that we should do a liver biopsy, and only if it is a definite alcoholic hepatitis or a possible alcoholic hepatitis, we should go ahead and give steroids. If it is only a probable alcoholic hepatitis, we should not give steroids. It will be detrimental to the patient. The next question comes, can we give steroids to a patient with infection? This was the study.
May I ask, sir, question regarding the biopsy? Most of this patient, when we are assuming a severe alcoholic hepatitis in our practice, community practice, having a INR, usually it's a derange more than 1.5. So via guideline, we have to go for transjugular liver biopsy. So this is not, usually patient does not agree for it because of the cost issue. So in such a case, without biopsy, is there any parameter you can clearly say, suppose this is like that, you should go, even biopsy is not feasible in alcoholic hepatitis?
So I think the places where I would probably skip doing biopsy is if the patient doesn't have any evidence of decompensation. That is, patient doesn't have ascites, there is no evidence of cirrhosis, there are no other competing etiologies. So typical profile would be a 30-year-old gentleman who is having very severe alcohol consumption for many, many years, last 5, 7, 8 years, very heavy drinking, and comes with very rapidly progressive jaundice. The SGOT is between 5 to 10 times upper limit of normal. The SGPT is less than 3 times upper limit of normal. and all other etiologies, including all viral markers, occult viral infections, all the serologies come negative. So in those patients, actually I do. But we have actually done the cost-benefit analysis in these patients. And if you really do all the serologies, the cost comes more than the biopsy cost. So a transjugular liver biopsy typically in private would cost you around 40,000 rupees, and the cost of the tests for all the viral hepatitis, overt and covert, will cost around 75,000 rupees. So that is why I think I would insist that we should do biopsy before we start steroids for patients with alcoholic hepatitis. The problem of INR, I would agree. In fact, unless the INR is deranged, your MADRS fraction will not be high, and therefore they would not be eligible for steroids anyways. So the reason for the patients who really need a biopsy are the ones who have abnormal INR. And that is why most of these patients would actually require a transjugular biopsy, like Dr. Somin said. So completely agree that these patients will require a transjugular liver biopsy, not a percutaneous biopsy. So patients who have not been, who are not infected before initiation of steroids versus those who are infected and treated with antibiotics before initiation of steroids do exactly the same, and their overall survival is the same. So you can, if you have treated the infection effectively, you can still start these patients on steroids. So confirm. Once you have confirmed that the patient's infection is cured, you can give steroids, but do not give steroids beyond 7 days. You assess the response to steroids on day 7. If there is a drop in bilirubin or the Lille score is less than 0.45, then only you will continue this patient on steroids, which will continue for 4 weeks and then stop. If you give prolonged steroids to these patients, then that itself is associated with increased risk of infections and increased risk of mortality. So we should not continue the steroids beyond 4 weeks in these patients. So like I said, what Dr. Somin said, transjugular, I've written it here also. So this patient was started on steroids plus nutrition plus supportive care. Day 7 bilirubin was 29, Lille score was 0.529, no encephalopathy, general condition looks better, appetite is better. So therefore, we had these 4 options, whether to continue steroids, do liver transplant, do FMT, or add antioxidants. And we actually decided to continue steroids, and he did well. So this is the Lille score, which we use for assessing response to steroids. Those whose Lille score is more than 0.45, the outcomes are poor. But if the bilirubin is dropping significantly after starting steroids, these patients will do well. And the probability of 28-day survival in those who are good responders, that is the Lille score is less than 0.16, complete response is really very high. So again, another study showing the same thing. And this is where those patients who had infection after the initiation of steroids actually do worse. And therefore, you should not prolong the steroids. So if you give steroids beyond 1 month, then at 2 months, the risk of infection goes up significantly, and that is associated with increased risk of mortality. So what about those patients who cannot be considered for steroids or those who do not respond to steroids? Do we have something else? The answer is yes, we can offer them liver transplant. But again, only a very small number of patients who are actually in need of transplant eventually reach the transplant table. So we still need a lot of options for these patients. We can give them experimental therapies like GCSF, or we can give them fecal microbiota transplant. But again, the options are really limited, and they do not work as well as in the clinical trial setting. So these are all the drugs which are there in the pipeline for severe alcoholic hepatitis beyond the steroids. And it'll be interesting to see which of these really reach the transplant table, the clinical table. So the combination of N-acetyl metatoxin is something which is already available, which is being tried. The other option is something called as canakinumab, and which is right now in phase 3 trial. And Senisiviroc is the one which was tried and which has failed. But let's see, the trial for alcoholic hepatitis is now going on. The trial which came negative was for NASH. And then you also have drugs acting on the gut-liver axis, like the anti-LPS and zinc supplementation, etc. So this is how now our algorithm has changed, that those who are steroid non-responders or steroid ineligible, you can try a GCSF. If it works good in those patients, you should give GCSF only if they're not candidates for transplantation. If they are candidates for transplantation, then don't waste time on any of the experimental therapies. You can straight away take these patients up for transplant. Now, before I wind up my talk, there are certain other indications of using steroids. The first one of them is symptomatic severe intrahepatic cholestasis as treatment of pruritus, especially in hepatitis A and hepatitis E. Those patients who have prolonged cholestatic phase beyond 4 weeks and have intractable pruritus, we can give corticosteroids for short duration, again for 2 to 4 weeks, to cut down the course of the disease. It does give symptomatic relief, but it does not, again, improve the overall survival. The second condition where we use steroids is for drug-induced liver injury. Very often, it will be very difficult to differentiate between drug-induced liver injury versus autoimmune hepatitis. Even histology can be the same. So this pattern of autoimmune hepatitis, like drug-induced liver injury, is caused by certain drugs like dapsone, minocycline, and few other drugs. So in these patients, we give steroids. We do not add azathioprine to these patients, and we try to taper off the steroids within 3 to 6 months and stop it completely. So within 3 to 6 months, the steroids will be stopped completely in drug-induced liver injury. Then we have herbal drugs-induced liver injury, the classical example being Giloy. There again, if the patient has deranged INR or if the patient has persistent prolonged symptoms, the transaminases are more than 10 times upper limit of normal, then we would offer corticosteroids to these patients. Once again, the steroids are for short duration. The steroids would typically be tapered off within 3 to 6 months in this population also. So in autoimmune hepatitis and autoimmune hepatitis PBC, PSC overlap syndromes is where you would give corticosteroids for long term, typically for 1 to 2 years. And once the patient are in deep remission, then you would want to taper off the steroids in this population and keep them only or mycophenolate mofetil. One more problem, which I am not able to cover for want of time, is when a patient with cirrhosis requires steroids for other indications, like for systemic lupus erythematosus, or patient has rheumatoid arthritis, or patient has developed another autoimmune disorder where steroids are required, or patient has developed lymphoma and you need to give steroids. So in those patients, we have to take sometimes very difficult decision that where even in the presence of cirrhosis, sometimes decompensated cirrhosis, we would typically give them steroids, but the monitoring of these patients has to be done with utmost care. Thank you very much, and I'll be happy to have any questions from all of you.
Hello. Any question from audience? Sir, dose of steroid in cholestatic phase of acute viral hepatitis A, cholestatic phase. Hello? 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 Okay, I think there is some connection problem. So now we are going to play quiz. तो आकाश साहब ने फ़ोन कर दिया सर कहीं को. And here is Dr. Sajan Agrawal. He is pediatric gastroenterologist just joined from Rajasthan just before few days in our hospital. So quiz will be on Telegram. I think many of you have joined this group. Okay, so it will be like the question will pop up on your phone Telegram group, and you have to select the answer. Akshay? So suppose first question will be, are you enjoying this conference or not? So there will be two options, yes and no. You can't change your answer once you clicked in. Okay, first thing. Second, there are 21 questions. Okay, so once you clicked in, you can see in your phone also, okay, I have done it right or wrong. And after that, when you see it is a right or wrong, you can see also who have given the first answer. Suppose, for example, can you give me this is the first question. Are you enjoying this CME? If you are in the group, you will see this question in your mobile, Telegram. Question will be there. Are you a part of the quiz group question? Praveen is excluded, gastroenterologist is excluded. तो आई जा, यहाँ आई जा भाई. Those who have difficulty, Maulik, go there. बात थी साहब जोड़े. Those who have difficulty, please contact Maulik or Akshay. તમે બાજુવાળા જે તમારા મિત્ર છે એ પણ તમને ગ્રુપમાં એડ કરી શકે, અથવા તો અક્ષય, જસ્ટ એડ ધેમ ઇન ગ્રુપ. એડેડ કેટલા જણા બાકી છે ગ્રુપમાં? You have to download Telegram. ભાવિન, ટેલિગ્રામ ડાઉનલોડ કરાવો. ત્યાં ગ્રુપમાં એડ કરે, એમને ટેલિગ્રામ છે જ. नहीं, उनके सब में मोबाइल में आएगा. अपने को पढ़, आपको भी तो आएगा मोबाइल में. तो इसको क्लिक करते ही ज्वाइन कर ले ना, मेरे में ले ले, कोई दिक्कत नहीं. अर्शिल, मारा मोबाइल आप. Everybody has joined? બાકી છે તમારે? ભાવિન, so you just click on some of this. Okay, everybody has joined? Suppose this is the question, are you enjoying this CME or not? Okay, this question will pop up in your mobile, okay, on Telegram group. We have to just, suppose I am clicking it right now, yes. Okay, so if we see the view result, do it view result.
28 answers, 100% yes.
Okay, so there are 28 answers. You can see in your mobile also. Sir, thyu tamare? You can see in your mobile also, there are 28 answers. Okay, 100% yes, but the people, the first answer will be, will be given by Akki, it means Akshay, that is our guy. જે સૌથી છેલ્લું નામ આવે એને સૌથી પહેલા ક્લિક કરેલું છે. સમજાઈ ગયું? So right now quiz will be handled by Dr. Agrawal. Okay, it may be possible for first one or two question it will be slightly unfamiliar to play a quiz, but it will be મજા આવે એવું છે. અમે આ ઘણી વખત અમારા ગ્રુપમાં પણ કરતા હોઈએ છીએ. ઓકે,
Next question.
Now the next question is all are the parameters of child score except option A HE, B ascites, C bilirubin, D albumin, E prothrombin time, F platelet count. Nobody answered. 17 answer. There are only 17 answers right now. Now increase to 20. इसको खोलना ओपन कैसे करें ओपन आंसर्स ओपन अच्छा ओके
Hello.
5% બેટરી
So result will be કોણે સૌથી વધારે સાચા જવાબ આપ્યા અને ઝડપી જવાબ આપ્યા બેના કોમ્બિનેશનથી છે એટલે માતાજીનું નામ લઈને આંગળી મૂકવાનું નથી.
So 42% have given the correct answer of platelet count.
નહીં, we will discuss it in the last.
Okay.
But you see right now there are 22 answer. You can see MELD score composed of all parameter.
And the first person who has given the answer is Golden Sparrow. Golden Sparrow.
Somebody's name in Telegram will be means is like golden. Yeah, it looks like Golden Sparrow.
The next question is MELD score composed of all parameters except bilirubin, creatinine, INR, sodium and potassium.
Yeah, that they have already given. Next question. Akshay. All scores are useful in alcoholic hepatitis except Madrid score, Glasgow score, Lilly score and Leipzig score. So there are 30 answer right now. Anybody is still left? Akshay, answer now.
Next question.
Nakhi de answer. Okay. This is a Leipzig score that is used in the Wilson's disease.
Next question is all of the following parameters indicates fibrosis directly or indirectly in various fibrosis markers except AST, platelet, gamma GT, ALT and alkaline phosphatase. सबने दे दिया आंसर
સિસ્ટમ નથી રાખી બાકી આમાં અડધા માઇનસમાં વહી જાય આપણે. So this is a alkaline phosphatase. Next question.
All are the indication of liver transplantation except hepatorenal syndrome, spontaneous bacterial peritonitis, acute liver failure and hepatic encephalopathy.
SBP is an indication for liver transplantation. Once patient develops SBP, he requires sooner or later liver transplantation. Okay. Hepatic encephalopathy is reversible and it is not a parameter that says that this patient require a liver transplantation. Next question. So, right answer is GI bleed. Apart from GI bleed, all are the indications for liver transplantation. Next question. So, Mallory's hyaline is the right answer. Next question. So, right answer is two types. It's a type 1 autoimmune hepatitis or type 2 autoimmune hepatitis. Next.
All are possible molecular can be tried for the treatment of gastric antral vascular ectasia except octreotide, cyclophosphamide, glucosteroid, thalidomide and methotrexate.
All can be used for the treatment of GAVE, octreotide, cyclophosphamide, glucocorticoids, thalidomide and methotrexate. Answer is a methotrexate. Apart from all these drugs are experimental. Though it is experimental, apart from the endoscopic organ plasma coagulation, we don't have much choice for treatment of GAVE. So this all drug can be tried with variable result. Next.
Following biochemical parameters is more specific for liver disease: SGPT, SGOT, alkaline phosphatase and LDH.
All 30 answers should be correct in this. તો મારો આ બહુ સફળ થયો ગણાશે. %83% is SGPT, that is the right answer.
Next. Serum alkaline phosphatase can be originated from all except liver, intestine, kidney, bone, placenta, RBC.
Alkaline phosphatase can be originated from all liver, intestine, kidney, bone, placenta and RBC, which is not an origin for alkaline phosphatase. RBC is the right answer. Next.
Next question. Wilson disease is purely responsible due to ATP7B gene mutation, HLA DRB103 gene mutation, DLA DRB104 gene mutation, and combination of ATP7B gene mutation and HLA DRB103 gene mutation.
It's a single gene mutation, ATP, HLA, or it's a combination of ATP plus HLA. So it's a single gene mutation. It is a ATP7B gene mutation. It is either heterozygous or homozygous. Next.
Drugs used for Wilson disease except penicillin, penicillamine, zinc, or triantine.
Which drug is not useful in Wilson's? Penicillin, penicillamine, zinc, or triantine? The answer is penicillin. Next, rest three can be used.
All are the antiviral except tenofovir, entecavir, adofovir, sorafenib.
Which is not antiviral? Tino, Enteca, Edi, or Sora? Next.
First emergency test in case of acute liver failure in emergency. Blood sugar, INR, ammonia, electrolytes.
You see, there is some catch in this question. It's an emergency test. Okay, emergency means the result should be easily available, and if you not treated it timely, okay, within hour or 2 hour, okay, patient may have grievous consequences. So INR may take around 2 or 3 hours to get your report. So it's a RBS. And second, the ALF is presented with the hypoglycemia, has a very poor prognosis. So you can directly refer them just after stabilization for transplantation. So usually this patient require transplantation. Next.
Decompensated chronic liver disease and hepatic encephalopathy. Options are serum ammonia must be sent, serum ammonia can be sent, serum ammonia not useful. Which is true?
So answer is serum ammonia is not useful. The message I want to convey, when it is a decompensated CLE and hepatic encephalopathy, ammonia will be raised only and there is no significance. The ammonia can be differentiated between it is due to the encephalopathy or something else, or in few prognostic model ammonia can be useful for the possibility of transplantation in acute liver failure. Most of the time I have seen during the referrals, even patient with the CLD are repeatedly we are sending ammonia, but which is not useful, nothing with the prognostic, nothing with the recovery also. Next question.
True about Gilbert syndrome and Crigler-Najjar syndrome is bilirubin is high in Crigler-Najjar and low in Gilbert's. Excellent survival in Crigler-Najjar syndrome. Liver transplantation is must for Gilbert. AST and LT always elevated in Gilbert. Which is true?
Out of these 4, which is true? Bilirubin is high in CJ and low in Gilbert. Excellent survival in CJ. Liver transplantation is must for Gilbert's. And AST-LT is always elevated in Gilbert. Next.
Next question. Most common cause of chronic liver disease in pediatric population: Wilson disease, autoimmune hepatitis, overlap syndrome, or NASH.
So answer is Wilson's disease. Okay.
Next.
Last question.
Which of the sentence is true in sense of obscure GI bleed? Melena present in occult GI bleed, melena present in overt GI bleed, hemoglobin drop very fast in occult GI bleed, hemoglobin drops very slowly in overt GI bleed.
This is obscure GI bleed. They have two type, occult and overt, out of which is true. Melena present in occult, melena present in overt. HB drops very fast in occult and HB drops very slow in overt. Second number. Answer કરી દે. So, melena present in overt GI bleed. Occult is mean gradual loss, stool OBT is positive, within a 2-3 month HB drops, okay, and you are not able to find a source. Overt obscure means sudden melena, HB drops suddenly, but till you are not able to identify source despite of everything. So, I think all questions are over. Within 2-3 minutes, we are going to discuss the result. Okay. You can, apart from Mike, you can conclude everything. Okay. So in next June we are going to update this similar type of update. Any specific feedback you want to give? This requires more improvement. This is little bit lengthy, or you have to curtail it for the 3 hours, because in 2018 I did it for the 2 days. It was a failure because it is too lengthy. In 2021